health awareness, to co-training future talents. From the foundational pillars of urology, China-Africa wisdom exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training through shared steps and shared struggles, China-Africa medical care is taking root ever branching out across the white-coated healer rise anew. The timeless truth through shared steps, health knows no borders. The journey every cross-border endeavor grows ever richer, echoes the noble calling each of the white-coated healer rise anew. The timeless truth clothed in white, health knows no borders. Together, every cross-border shine toward the dawn, echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. Clothed in white, to be the light, to empower life. Together, we shine toward the dawn. The light, may the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light has set sail. From China's fertile lands to the boundless African savanna, waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and bringing fruitful collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand in hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration health to communities across to co-training future talents. From the foundational pillars of urology, China-Africa wisdom exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training through shared steps and shared struggles, China-Africa medical care is taking root ever branching out across the white-coated healer rise anew. The timeless truth through shared steps, health knows no borders. The journey every cross-border endeavor grows ever richer, echoes the noble calling each of the white-coated healer rise anew. The timeless truth clothed in white, health knows no borders. Together, every cross-border shine toward the dawn, echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. Clothed in white, to be the light, to empower life. Together, we shine toward the dawn. The light, may the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light has set sail. From China's fertile lands to the boundless African savanna, waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and bringing fruitful collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand in hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration health to communities across to co-training future talents. From the foundational pillars of urology, China-Africa wisdom exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training through shared steps and shared struggles, China-Africa medical care is taking root ever branching out across the white-coated healer rise anew. The timeless truth through shared steps, health knows no borders. The journey every cross-border endeavor grows ever richer, echoes the noble calling each of the white-coated healer rise anew. The timeless truth, clothed in white, health, we become the light. Together, every cross-border shine toward the dawn, echoes the new the friendship between China and Africa. Bloom in every corner of the world, clothed in white, to be the light, we become the light, to empower life. Together, we shine toward the dawn. The light made the friendship between China and Africa. Bloom in every corner of the world, to be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and beauty in their heart. Collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration health to communities across to co-training future talents. From the foundational pillars of urology, China, Africa, to the pioneering exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training through shared steps and shared struggles, China, Africa medical care is taking root ever branching out across the white-coated healer, rise anew. The timeless truth through shared steps, health struggle borders. The journey every cross-border endeavor grows ever reaching echoes the noble calling. Each of the white-coated healer rise anew. The timeless truth, clothed in white, health we become the light. Together, every cross-border shine toward the dawn, echoes the noble calling. The friendship between China and Africa. Bloom in every corner of the world, clothed in white, to be the light, we become the light, to empower life. Together, we shine toward the dawn. The light made the friendship between China and Africa. Bloom in every corner of the world, to be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and beauty in their heart. Collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration health to communities across to co-training future talents. From the foundational pillars of urology, China, Africa, to the pioneering exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training through shared steps and shared struggles, China, Africa medical care is taking root ever branching out across the white-coated healer, rise anew. The timeless truth through shared steps, health struggle borders. The journey every cross-border endeavor grows ever reaching echoes the noble calling. Each of the white-coated healer rise anew. The timeless truth, clothed in white, health we become the light. Together, every cross-border shine toward the dawn, echoes the noble calling. The friendship between China and Africa. Bloom in every corner of the world, clothed in white, to be the light, we become the light, to empower life. Together, we shine toward the dawn. The light made the friendship between China and Africa. Bloom in every corner of the world, to be the light, to empower life. And now, the light had set sail. China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and bringing fruitful collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration to communities across to co-training future talents. From the foundational pillars of urology, China Africa wisdom exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training future talents and shared struggles, China Africa medical care is taking root ever branching out across the light-coded healer rise anew. The timeless truth through shared steps, health struggles. The journey every cross-border endeavor grows ever reaching echoes the noble calling. Each of the light-coded healer rise anew. The timeless truth clothed in white, health we become the light. Together, every cross-border shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. Clothed in white, to be the light, we become the light, to empower life. Together, we shine toward the dawn. The light made the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and bringing fruitful collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration to communities across to co-training future talents. From the foundational pillars of urology, China Africa to the pioneering exploration is taking root of minimally invasive surgeries across the continent. From spreading health awareness to co-training future talents and shared struggles, China Africa medical care is taking root ever branching out across the light-coded healer rise anew. The timeless truth through shared steps, health struggles. The journey every cross-border endeavor grows ever reaching echoes the noble calling. Each of the light-coded healer rise anew. The timeless truth clothed in white, health we become the light. Together, every cross-border shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. Clothed in white, to be the light, we become the light, to empower life. Together, we shine toward the dawn. The light made the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time for preserving China's fertile lands with the boundless in their African and beauty in their heart. They kindle waves of Chinese and African healers have been racing against time. We synergize medical expertise with skill and experience in their hands and bringing fruitful collaboration to communities across the life, wherever they go. From the foundational pillars of urology hand to the pioneering exploration medical expertise of minimally invasive surgeries, bringing fruitful collaboration health to communities across the land. From the foundational pillars of urology to the pioneering exploration of minimally invasive surgeries, from spreading health awareness.
Hello everyone, and good morning, distinguished African colleges, and good afternoon, Chinese urologists online, and welcome everyone. This is the third time session of the CAUA surgery exploration distinguished African colleges, and good afternoon, Chinese urologists medical online, and welcome everyone. This is the third time host session of the CAUA and this event is jointly organized by China from the second hospital of Tianjin Medical University, CAUA, and the CUA to the Pan-African Program. And this event is jointly organized by our hospital, Africa, and our sincere gratitude to all organizers for making this high-level academic Pan-African. We are truly honored to have the support organized by our hospital, Professor Zhang Xi, and our sincere gratitude to all organizers for making this high-level academic Professor Yuanjie. We are truly honored to have the support Tianjin Medical University General Hospital, Professor Zhang Xi, and Tianjin Institute of Urology of the CUA, and Dr. Mobile, Professor Yuanjie from his president of the Tianjin Medical University General Hospital, and Tianjin director from our hospital. In addition, distinguished panel of experts from China and Africa will General Hospital and Professor the session. Urology director from our hospital in next session. In addition, and distinguished panel of experts from China and Professor Liu Liwei of Professor Wang the session. Professor and we will introduce themselves in next session. We are all from the second hospital of Tianjin Medical University. Our professor actually look forward to today's discussion with our colleagues from China and Africa. Now, let's begin we are all from the second hospital of Tianjin Medical First, I will invite actually look forward to today's discussion with our colleagues from China and Africa. Now, let's begin the play the video program. And first, I will invite Professor Liu Yanjie to deliver his opening remarks. Perhaps
Dear Professor Zhang Xi, and dear Professor Mobile Tampaga, dear colleagues from China and Africa, it's my great honor to give this opening address on the third CAUA Surgical Express on dear Professor, on behalf of CAUA and on behalf of Tianjin Medical dear colleagues from China and Africa, and it's my great honor to give this opening address. I send my warmest greeting to all the colleagues Surgical Express on air. For the last year, CAUA and CAUA Tianjin Medical University collaborated between and Chinese and African Tianjin Institute of Urology through online my warmest greeting to all the colleagues from China and Africa. For the last year, program, CAUA has deepened a strong collaboration between Chinese and Africa urologists. And this is the online training, we broadcast surgery and surgical demonstration this year, and education programs. This will CAUA has helped young doctors bridge from connecting China and Africa by improving their technology. This is the third time, and I also broadcast the surgery to use this opportunity to welcome. This will have Africa colleagues, young doctors, come to China to join our 2026 CAUA meeting. And I also November 20th. We are looking forward to welcome with our Africa colleagues. Come to China. We hope to join our 2026 CAUA meeting. Finally, I wish this third we are looking forward to collaborate with on our friends great success. Thank you very much. Thank you. I hope we will build a friendship in the future. Finally, I wish this third CAUA Surgery Express on air a great success. Thank you very much. Thank you.
Okay, thank you, Professor Liu Yanjie. Next,
dear professors,
I would like to
dear colleagues, members
Dr.
of
Mobile
CAUA
to give his
and
opening address.
CUA and COSA, dear participants. It's a very great honor for me to speak today before this dear colleagues, forum. Members of the first time CAUA offers to urologists from China and Africa an opportunity to come together and dear participants. It's a very great honor for me to speak today before this prestigious forum. That for the third time, CAUA offers to urologists from China and Africa. I would like to come together and distinguished members of the CAUA experiences and the CUA innovation committees that have. We are very grateful to China Africa Urological Alliance initiative. I would like to work for President of the POSTA commitment, distinguished members of the CAUA and medical cooperation and the CUA committees. We are very grateful to China Africa Urological Alliance initiative for its commitment and efforts to promote scientific and medical cooperation. Dear professors, dear colleagues, ladies and gentlemen, technology now is no longer simply to treat disease, patients and faster recovery for our patients. That is the added benefit of thulium laser and robotic surgery. We know that stone disease present a significant public health issue worldwide. Technology now is no longer simply to treat disease, patients and faster recovery for our patients. That is the added benefit of thulium laser and robotic surgery, the gold standard for. We know that stone disease present a significant public health the emergence worldwide. Of the thulium laser, Africa and China marks a new stage in the evolution of not only BPH treatment but also the thulium laser endoscopy, the gold standard for urinary stone fragmentation. However, the thulium laser offers several significant advantages. Marks a new stage thanks to better energy not only by water, but also it enables more efficient stone fragmentation treatment, producing extremely fine particles easily eliminated. The thulium laser offers several significant advantages. Thanks to better energy absorption by water, it enables more efficient short fragmentation, better producing extremely fine particles easily eliminated interventions. Today, by reduction the phenomenon became indispensable tool in significantly improves surgical. The second topic I would like to address is robotic surgery times, better stone-free rates, represent one of the greatest surgical revolution interventions today. The thulium laser has to high definition three-dimensional urological procedure, exceptional precision. The second topic I would like to address is robotic surgery instruments and optically ergonomics. It provides the greatest surgeon can perform complex procedure with a level of fineness that is difficult to achieve with exceptional precision of movement provided by articulated neurology. It application improves the ergonomics. It provides surgeon can perform complex procedure with a level of fineness that is difficult to achieve with conventional short laparoscopy and prompt patients. Neurology, its application, of course, are numerous, particularly regarding acquisition costs, training of surgical teams, equipment maintenance, and the continuous supply of specialized consumables. These technologies, which are gradually being introduced in Africa, are not simply new tools. Of course, they represent a new way of approaching training of surgical teams, one that is centered on precision, continuous supply of specialized consumables. The future of technologies which are gradually being introduced in Africa are not simply new tools. In our they represent a new way of approaching to the African Society of Laparoscopic and Robotic Surgery, safety and effort to promote these innovations as well. Our discipline depends on the way we integrate these innovations in our centers across Africa. Congratulations to the African Society of Laparoscopic and Robotic Surgery for its efforts to promote these innovations as well as creation of functional centers across Africa. Tremendous disparities in collaborative research have made these advances possible to a greater number of patients. I'm convinced that the scientific exchange taking place during this forum and Africa constitute another important step toward achieving collaborative research and make these advances possible to a greater number of patients.
Thank you,
that
Dr. Kampaka, for your excellent saying. And dear college, and the main event is now opening us our critical demonstration and discussion will be jointly Kampaka for your excellent sayings. And now to college and the main event is now Professor our critical demonstration and discussion will be jointly by the on the rating teams. Let's now turn to a very warm first group to you. And the subsequent session will be managed by the respective moderator groups. Okay, and Professor, let's see the operating room. A very warm welcome to you. Prepared, and the subsequent session will be managed by the respective moderator groups. Okay, let's see the operating room.
Hi,
If the
Dr.
operating
Wu.
prepared. Hi.
So
Okay.
welcome for your introduction. So let's move to our part now.
Yeah.
Okay, so it's a great honor for me to here to co-moderate this live show. Welcome for your
between the China and Africa.
So let's move to our part now.
Just introduce our two
Okay, so it's a great honor for me
American
to
friends.
Here to
It's Dr.
co-moderate this live
show.
I don't know if my pronunciation is right or not.
So let me just introduce our
the next
two
doctor from the
American
South
friends.
is Dr.
It's
Kent
Dr. Luke.
Attendance Tadasa. I don't know if my pronunciation is right or not. Oh, the next doctor from the South Africa is Dr. Kent. So let me introduce our two Dr. Kent Pluk is from the South Africa, and it's yeah. So let me introduce our famous university, our Dr. So his major is South Africa and biotechnology, especially have a lot of experience in the Hollywood famous university. So I think the next case is Solium. So his major is BPH and biotechnology. So especially have a lot of experience in the Hollywood Solip. So I think the next case is Solium. One is our friend is Dr. Of the BPH. So we have please show us about the holip and the solip, tulip. So the next one is our friend is Dr. Is also from the doctor from the Ethiopia and also have a lot of memberships in modern urology for Africa and also have a global surgery is also from global surgery, especially the urology, and also have a lot of memberships editor of urology journal, modern urology for Africa, a lot of reviewers for different urology journals. So welcome you to global surgery, especially the urology. Also start of the next guest editor of the urology good journal. And also be a lot of reviewers for different urology journals. So the next operation is welcome you to fabulous indication of prostate. Start and the surgeon is Professor Liu Liwei. So maybe yes. Dr. Liu is from the second hospital. So the next operation is in China, and they also have a lot of academic and the surgeon is Professor Liu Liwei in the Chinese Association of Integrative Dr. Liu is from the second Chinese Urology Association in China, Urology Medical Doctors Association. Also academic and social chairman of the BPH special Chinese Association of Integrative Medicine, also the Chinese Urology Association. Chinese Urology Medical Doctors Association. Maybe also he's a chairman of the BPH special committees in Tianjin Medical and Health Association. I think he's ready now.
Hi.
Maybe we can. I'm Dr. Cui from Shanghai General Hospital.
Hi, Dr. Cui. Hi, Dr. Cui. This is Dr. An from the second hospital of Tianjin Medical University GU department. I'm the assistant of Dr. Liu, and here is my honor. And please let me do a very brief introduction about this patient and from the second hospital of this Tianjin Medical University GU department. I'm the assistant of Dr. Liu, and so this operation is lithium fiber laser enucleation of prostate and the patients and the operation is broadcasting from China. And the surgeon of this operation is Dr. Liu Li. Okay. So the information of this case is a 68-year-old fiber laser and his enucleation of prostate. The patients and the operation is urination for over 2 years. And the surgeon of this operation is Dr. Liu Li. He has the hypertension for over 3 years, and he already did the male biopsy at another hospital 1 year ago. The pathology report difficulty in urination for over 2 years. The main symptom, let's quickly go through this past history. He has the hypertension for over 3 years, and he already did the hesitancy and the dribbling with 1 year ago. The pathology report, and he has the bacteria. The main symptom 1 to 2 times per night is he has the weak urinary hematuria. This symptom progressively worsened, and the dribbling without the medication therapy for over he has the bacteria 1 to 2 times per night. Partial relief. 1 year ago, due to the alcohol intake, this symptom progressively urinary retention. He already received the medication therapy for over, after which he resumed the spontaneous voting. It indicates that the patient already received the 1 year ago due to the alcohol intake. The patient experienced acute urinary retention requiring the PSA is catheterization, after which he resumed the spontaneous voting. So also the patients already received blood and the urine test, the liver kidney function within normal limits. And the laboratory test shows that the PSA score is 19 and the quality of his lab score is 5. So also the routine blood and the urine test, the liver kidney function within normal limits. According to the patient's examination, the size of 19 prostate and the quality of his lab score is monitored by his BMI is 25. The volume of the prostate is 82.95 milliliters. So the average according to the urine flow rate is 41. The size of milliliter prostate is second, and the max flow rate is 12.4 and multiplied by 7. The volume of the prostate is 82. Let's move on to the patient's MRI. So the average of the urine flow rate is 41 milliliter per second. Protruding to the bladder. Flow rate is 12.4. Switch to the camera to Dr. Liu. So let's move on to the patient's MRI. You can see that the prostate is obviously protruding to the bladder. So let's switch to the camera to Dr. Liu.
Hi, Dr. Liu. I think you are just started your procedure. So the first section is the 12 o'clock.
Yes.
Hi, Dr. Liu. I think you are just started your procedure. So the first section is the 12 o'clock. So do you have just to do the performance of 5 o'clock or 7 o'clock?
Yes.
Before the 12 o'clock section, or just the first section is the 12 o'clock part? So do you have just to do the performance of 5 o'clock or 7 o'clock? Before the 12 o'clock section, or just the first section is the 12 o'clock part?
Dr. Liu will go the 12 first, and they don't do the 5 or 7 first.
So yes, I think we have to distinguish the urologist from Africa.
Dr. Liu will go the 12 first, and they don't do the 5 or 7 first.
So yes, I think
Dr. Liu will not do the resection go through the 5 o'clock or 7 o'clock.
Dr. Liu just do
it's
the
an
unblock. So there is a routine procedure in your practice, no matter how big the size of the prostate,
do the resection go through the 5 o'clock or 7 o'clock.
Unblock, others
it's an unblock.
3 lobes or the 2 lobes. So there is a routine procedure in your practice, no matter how big the size of the prostate, or just you choose some part of the patient.
It's a routine practice for Dr. Liu to all the patients.
Okay.
That's a good question.
So I think Dr.
It's a routine practice for Dr. Liu to all the patients.
Yeah. So do you do the whole? So I think Dr. Enucleation in your hospital.
In our hospital, we do Holly. we usually do
So do you do the
in
whole
block,
or
but
the sodium
we start from 5
with
to 7.
inoculation in
但是反能量再调低点，包
And
括
usually
再明
in
显
our
一点。
hospital we do polytunnel,
Okay.
and we usually do the inverted U incision around the varus. Then we start from 5 or 7 o'clock.
但是反能量再调低点，包括再明显一点。
My practice is more focused on the sodium,
Make
but
the
I
inverted
don't do the
U
en bloc
incision
one.
around the varus first.
So I just use 2 lobe
5 or
or
7
just 3 lobe
incision, then inoculation continues.
method. So what about you, Dr.
So my
Kent?
practice
I think you have a lot of experience about the sodium, but I don't do the en bloc one. So
Yeah, I mostly
use
do
2
only
lobe or
early
just
on
3
in my
lobe
training. I started doing some thulips, but I found it
So what
quite
about you, Dr.
difficult
Kent?
initially
I
because
think you have a
of
lot of experience about
the plane. I found it more difficult to get a good plane. So yeah, I mostly do only steering away from the on-block technique. I started using the thulips, but I found it quite and I would do a 3-lobe technique. But now that I've switched, I personally mostly do plane. I found it more difficult. I find I can see the plane quite easily, and I find myself only do steering away from the on-block technique these days. Using the thulip. So I'm quite interested to see how and I would do a 3-lobe technique. But now that I've switched, I personally mostly do whole lips thulium fiber laser. I find I can see the plane quite easily, and I only do on-block enucleation to learn these days.
So
I'm quite interested to see how
differences about
how they negotiate to get that nice plane with the thulium fiber laser. I'm very interested to see this. I must say, initially, I would say the first to learn year initially it was higher incontinence rates, but they always recovered after about 6 months. But nowadays, I think because we're doing early apical release, I would say the first I'm very strict on doing initially apical release from the sphincter. Higher incontinence rates, I don't see much incontinence except for the elderly patients with very big nowadays, I think because we're doing early apical release, they seem to have a bit more incontinence, strict on doing but they usually recover by 3 months now. So I think it's a little bit about making sure you release that patients with very big prostate. So if the prostate is over, if they've got a very large prostate, they seem to have a bit more incontinence. You might but they usually recover by 3 months, and we start Kegel so I think it's a little bit about floor muscle making sure you release early on in that before they even get the operation. And if they've got a very large prostate, for the big prostates, because I anticipate that they might have some incontinence for the first few months, and we start Kegel exercises or pelvic floor muscle therapy early on in their before they even get the operation. We start the pelvic floor muscle therapy for the big prostates because I anticipate that they might have a bit of incontinence. I don't know what the rest of the team think.
Blood neck. Yeah. So I think this case is very interesting because it only have it's not only just perform very quickly. We can see now the IPP is very close to the blood neck. The IPP is more than 1. So I think this case is very interesting because it patient with a higher IPP. Do you recommend the medical the IPP is first or big? I think the IPP is more than 1 go to the centimeters of surgery as well as possible. All these patients with a high IPP, do you recommend the medical treatment first or just tell them to go to the surgery as well as possible?
I won't advise,
不需要，这个中叶突出的药物治疗效果是不好的。
So, hi, Dr. Cui. Thank you for your question. So, according to these patients already take the medicine treatment before, but it's only have the partial relief. And I just asked Dr. Liu for your excellent question. Hi, Dr. Cui. Thank you for your question. So, according to these patients already take the medicine treatment lateral, but it's only have the partial relief. And protruding to the Dr. Liu for your excellent question. Always fail. Dr. Liu said about the patients medical middle medication therapy before the surgery, lobe which protruding to the bladder. So this kind of patients always fail about the medical the medication therapy before the surgery. Thank you. More than one.
So, how big the IPP is less, more than 5 millimeters, or just more than 1 centimeters? Yes.
Comparing the holmium laser to the thulium fiber laser, is there any learning curve difference? Is it easier to learn one over the other? Comparing the holmium laser to the thulium fiber laser, is there any learning curve difference? Is it easier to learn one over the other?
就是他说学习曲线两种学习曲线有区别吗
？Tulip 相对更容易一些，因为它这个止血效果好。但是寻找包膜层的话要有一定的经验。
就是他说学习曲线两种学习曲线有区别吗
？Tulip 相对更容易一些。
Hello, Dr. C.
因为它这个止血效果好。
It's Dr. Kent from the South Africa.
但是寻找包膜层的话要有一定的经验。
Dr. Liu said the one millimeters laser have the better ability to stop bleeding, and it's easier to find the layer of the prostate. Dr. Liu said the 1 millimeters laser have the better ability to stop bleeding, and it's easier to find the layer of the prostate.
Because just Dr. Liu mentioned the bleeding control is better in opinion. I think the learning curve about the solium. Another thing I can say the solium can do a lot of things, not just because just Dr. Liu mentioned the bleeding control also can do the vibration. So if you miss another thing I can say the solium can do a lot of things, not just do the vibration in your calculation. We also can do the vibration. So if you miss the lane, the plane,
point well taken there that you can evaporate the tissue if you lose your way a little bit, which does make a big difference early on in the learning curve, I think. I found myself quite frustrated initially. Point well taken. You're not in the right plane, and you can evaporate the tissue if you then you lose your. It can be quite challenging, and I think which that's one of the problems on in the learning curve. I think anatomical enucleation. I found myself quite frustrated initially. A lot of doctors who you're not in the right plane, and there's a bit of bleeding. Start out with your training, then it can be quite challenging, and I think that's one of the problems in the operating 3 or 4 hours anatomical enucleation, and that makes people stop doing enucleation for years, or start out with your training, lose their way with big prostate, and then it's very, very frustrating. You end up operating for 3 or 4 hours on a patient, and that's what makes people stop doing enucleation of the prostate.
Compared to the HOLIP, do you have any? Yes, so for the bleeding control, also you as an expert in the lasers. So you can see the solium is very much better. Do you think it's much better in the solium? Compared to the HOLIP, do you have any think about the bleeding control compared with the two lasers? It's much better. Do you think it's much better in the solium?
Yellow solium 这个就看个人喜好吧，就有的人喜欢爆破，有的人喜欢切割，可以调到一个中等的参数，也有爆破也有切割，这样止血效果也好。这个就看个人喜好吧，有的人喜欢爆破，
it's according to individual's interest. So some doctors like have the more ability, strong power to cut. Someone choose to Dr. Liu says so. It's according to individuals' interest. Some doctors like the medium ability, more ability, strong power to cut. Someone choose to pumping. So he has the interest to choose the one have the medium ability of all the parameters. Thank you.
Question?
Yes, please.
Yeah, one of the reasons that they advocate for early apical release is because of short-term incontinence risk. So
yes,
how's because now we have not one of the reasons that apical release first. They advocate for early apical release is because of short-term incontinence risk. So is there any difference, like, because now we have looked at apical release first. So how is that different?
Sorry, Dr. Atini, maybe the connection is not
Is there
good.
any difference?
Repeat
My question is, one of the reasons that early apical release is advocated is because of early incontinence.
Maybe
so
the connection
is there any difference when?
So can you repeat
Because now my question is, one of the reasons apical release first, early apical release is advocated is because the question is there any difference? So is there any difference when? Because now they haven't done any apical release first. They went directly to the bladder. So the question is there any difference?
我也没听懂，他就是我听的意思就是说，这个技巧上有没有什么区别？
什么技巧？
我因为口音我也没听懂。
我没有听懂，我不知道你听懂了没有？你们前期的那个。
我也没听懂，他就是我听的意思就是说，这个技巧上有没有什么区别？What skill you mentioned？ 因为口音我也没听懂。
Apical release, meaning the first step that we do here.
Hi, Professor. Yeah, sorry for the misunderstanding. What skill you mentioned?
The 5 or 7 o'clock apical release. That one I have seen now. The first step that we do incision for Holepit, followed by inoculation. So the question is, we will proceed. Like, does it have any difference with the 5 or 7 o'clock incision? That's what I have seen now is the 12 o'clock incision, outcome from your hospital, followed by inoculation. So the question is, like, does it have any difference with the early release papers, early apical release papers? Okay, outcome from your hospital.
习惯不一样吧？
哦，
有区别。
It's just Dr. Liu said it's just a habit of each surgeon. Not a big difference. And I think the outcomes come similar. Oh, it's just Dr. Liu said it's just a habit of each surgeon. Not a big difference. And I think the outcomes come similar.
So remove the lobe from the medial lobe first. In my own practice, I just do the 5 o'clock or 7 o'clock section first. So then, because I do the maybe especially with the patient with have a large medial lobe. I have performed several medial lobe first, but I think the post-operation incontinence section is much higher than because I do the 2 lobe or 3 lobe section. So I switch to the. I have performed several unblock ones, but I think post the operation incontinence is much higher than the 3 lobe or 2 lobe method. So I switch to the 2 lobe or 3 lobe. So Dr. Liu, you do the unblock one. So after the post the operation incontinence, the rate of post operation incontinence is 1 or 2%. So Dr. Liu, you do the unblock one. So after the post the operation incontinence.
Sorry, Doctor, could you repeat the question again?
术后尿失禁 operation incontinence is
术后尿失禁
1 or 2%.
在做剜除的时候，首先要把肩部的这个腺体给处理掉，就是把肩部黏膜、肩部腺体完全游离。这样的话，你在做这个后边的。 在做剜除的时候，首先要把肩部的这个降到最小，给置于误操处理掉，就是把肩部黏膜几乎很少，只有少量的轻微的压力性尿失禁。这个增性尿神经是不会出现的。这个步骤的时候，对括约肌的损伤就降到最小，不至于误操作。这样术后尿失禁几乎很少，只有少量的轻微的压力性尿失禁。增性尿神经是不会出现的。
Dr. Liu just mentioned that he will cut the mucosa at the apex side, then we can just decrease the tension. We just discussed about the post-operation incontinence. After the surgery, Dr. Liu just mentioned that he will small patient, very small percent patient at the apex side, then we can just decrease the tension. It can recover very soon. Sphincter. So. After the surgery, only when you do the small patient, very small percent patient, Dr. Sarfas and Dr. Kent, do you cut the incontinence mucosa? It can recover very soon at the apex site first. So when you do the HOLIP and in Dr. Anis and Dr. Kent,
Dr. Tedeschi, do you want to answer first? I'm just going to switch to my computer.
Site first. So we just talk about the post-operation incontinence.
Dr. Tedeschi, do you want to answer first? I'm just going to switch to my computer.
Overdue incision in front of zero. Then we will make
so we just talk about the post-operation incontinence.
What we do is the apex in like the whole lateral lobe and the apex, so it's gonna be a kind of circular thing in front of zero. In front of the zero, a marking incisions around. We just do it first.
Oh yes.
The apex in like the whole lateral lobe and the apex, so it's gonna be a kind of circular thing in front of the vero. So
the unblock
we just do it first.
Enucleation is so fast. Only I think maybe 20 minutes.
Yeah. Just a question. In block, I think when the gland is a bit bigger, in block is a bit difficult.
So fast. Only I think maybe 20 minutes.
So it's just it should be either 2 lobe or 3 lobe. Just a question. In block, or like for average size, I think when the gland is a bit bigger, in block is a bit difficult.
Yes.
So
Dr. Liu, so if
it should be either 2 lobe or 3 lobe technique. For average size, in block
also to the unblock, also
something manageable, I think.
3 lobes technique. So Dr. Liu, so if you have a very big prostate,
肯定得弯曲。
我的意思是整叶切还是分叶切
？N block 都是
N block 都是做 N block， 不是个大整叶切。
So when you meet the very big prostate，
肯定得弯曲。
prostate， 我的意思是整叶切还是分叶切
？N block 都是
N block 都是做 N block， 整叶切。
So when you meet the
整叶切的话也是先一侧处理，只不过5-7点不用打勾，这样可以节约时间。
So do you have any experiences about this?
5点7点不用打勾，这样就可以节约时间。整叶切的话也是先一侧处理，只不过5-7点不用打勾，这样可以节约时间。
Unblock also, but he will not go through the break through the
5点7点不用打勾，这样就可以节约时间。
Save the time. Dr. Liu said he will choose unblock also, but he will not go through the break through the 5 o'clock and the 7 o'clock. Yeah, he can always do the 12 save time section first. Yeah.
But you just do the 12 o'clock section first.
Yes, he always do the 12 o'clock section first. Yeah.
Is thulium more popular in China than holium?
I think it depends on the hospital's areas.
Is thulium more popular in China?
Have the solium or the holium. Maybe they choose holium more. I think it depends on the, as you know, the students we depend on the hospital's areas. And if every hospital have the solium or the holium, maybe they choose holium more. If you have the solium laser, I think as you know, the students we use the solium. Holium. So I think every hospital in China have the holium laser. Choose the holium. If you have the solium laser, I think a lot of doctors maybe choose the solium.
调小吧，能量调小，直至血。那个高层连续吧，完了。
So now it's we can just control the bleeding, and Dr. Liu just mentioned it will decrease the energy.
调成连续吧。
To just have the bleeding control. So now it's we can just control the bleeding, and Dr. Liu just mentioned it will decrease the energy, and to just have the bleeding control.
没事，就这样吧。这个结儿给它去掉。没事，就这样吧。这个结儿给它去掉。
哎，秦华，我问一下，那个你那个病人啊，他是肺多发是什么原因？哎，秦华，我问一下，那个你那个病人啊，他是肺多发是什么原因？
外国专家问您这个您就是做不做这个肩部玉离断？那做，开始就是玉离断的。这括约肌啊，已经玉离断了。问您这个您就是做不做这个肩部玉离断？那做，开始就是玉离断的。就这个激光，它的优点就是止血好，视野清楚，已经玉离断了。
Can I ask how long you keep the catheter
这个
in
激光
for
它的
after
优
the
点就是止血好，视野清楚。
导尿管放多久？
导尿管放3到5天。
Can I ask how long you
2、3
keep
天
the
也行。
catheter in for
看这
after
个
the
有时候也
procedure?
看腺体的大小，小腺体出血
导尿
少的话可以
管放多久？
少带2天。导尿管放3到5天，2、3天也行。看这个，有时候也看腺体的大小。
says
小腺体
maybe
出血少的话，可以
3
少带
days
2
after the procedure, it doesn't move the catheter, and depending on the volume of the procedure. If the patient have a small one, maybe says we can just remove the catheter earlier, 3 days after the procedure, maybe it doesn't move the catheter, 5 days. And depending on the volume of the procedure, if the patient have a small one, maybe 1 days after the we can just remove the catheter earlier. But if you have a large one, maybe
Yes, I usually remove the catheter the following day also. So most patients will have a catheter for 24 hours. Is there a specific reason that you keep the catheter in for so long, for 3 or 4 days? Yes, I think most usually remove the catheter the following day also. Performing most patients will have a catheter for usually 24 hours. Is there a specific 24 to 48 hours that you keep the other reason for us for so long, for 3 or 4 days? The funders, because you're privately funded performing they want the patients out of hospital within 24 to 48 hours. So we generally take the catheter out before then. Us at least is that's the other reason we the funders get the catheter out early. As soon as the urine privately is funded, the catheter. They want the patients out of hospital within 24 to 48 hours. So we generally take the catheter out before then. So it's that's the other reason we try and get the catheter out early. As soon as the urine is clear, we remove the catheter.
我们有的也带的时间也是转天拔，
有人说他问
或者第2天拔，但是有一部
放这么长
分
时间，
患者呢，
就是大部分都是1天。
膀胱功能恢复的差一点，或者是这个有水肿，我们有的也带的时间也是转天拔，或者第2天拔，但是有一部分患者呢，可能所以后边功能恢复的差一点，或者是这个有水肿，他拔的早了，也有一小部分患者可能还得尿不出来，还得再重新插上，所以后边呢就是延长了一点拔管时间，准备粉碎器了。
只要我们听不见你说的，他说的是。So the answer from Dr. Liu says, they just try to remove the catheter 1 or 2 days after the procedure, but some of them just can't. So the answer from Dr. Liu says, normal urine. They just try to remove the catheter 1 or 2 days after the procedure, but some of them just counter. But in my own hospital, we just do the 1 or 2 days normal urine. But for the smaller, especially for less than 30 microliters per liter, we just allow the but in my own hospital, we just do the 1 or 2 days after the procedure. For the larger one, for the smaller, especially for less than 30 microliters per liter, so what's your experience allow the catheter time? Maybe
we generally do the same thing with
for the
after
larger
24
one,
hours. Within 24 hours, sometimes we will just remove the catheter as long as the urine is nice and clear. We would remove the catheter as early as possible. We generally do. Sometimes it's more 24 hours. Within 24 hours, sometimes we will just out of hospital remove the catheter. It's not ideal. Is nice and clear. We would remove the catheter as early as possible with a catheter. But sometimes it's more. But we generally follow the same rule out of 1 or 2 days. A catheter, which is not ideal, is coming out because patients don't really like going home with a catheter in our setting. But we generally follow the same rule. Within 1 or 2 days, a catheter is coming out.
He's able to void or not. What we do is we just remove. If he's not able to void, or if he has, the patient will be catheter free by hematuria. During the round, like a gross hematuria, then we'll put it back and send him or not, so that he can come back for. If he's not able to void, or if he has.
Yes, I think our practice is very similar.
Then we'll put it back and send him home so that he can come back for catheter removal.
So how about the bladder irrigation? How long?
Yes, I think our practice is very similar to yours, Dr. Tadasa. Very similar.
It depends
so
on
how
the
about
day.
the bladder irrigation? How long?
Friday, and if you want to sleep, then just put him on continuous bladder irrigation.
Yes.
But usually it depends on the day. Usually you can stop it by Friday around, and if you want to sleep, then just put him on continuous bladder irrigation.
Yes.
But usually no one wants to be woken up and just. So usually you can stop it by like around 8 p.m. You just keep on reading. It keeps on going. No one wants to be woken up and just.
What about you, Dr. King? About the bladder irrigation?
Yeah, we generally
just keep on reading.
We usually stop it also the following morning very early at about 6 o'clock in the morning. Stop the irrigation. If it stays clear, remains clear for the next 2 or 3 hours, and then we will remove the catheter. We usually stop it also the following morning very early at about 6 o'clock in the morning. Stop the irrigation. If it stays clear, remains clear for the next 2 or 3 hours, and then we will remove the catheter. That's sort of how we usually do it. And in your experience, how many would you say, the learning curves are different for different people, but how many cases do you think, or do you see most guys who are learning or starting out with a tulip would you say before they get learning curves operating times or stable operating times and how many quite comfortable doing the procedure? Do you think, or do you see most guys who are learning or starting out with a tulip are taking before they get good operating times or stable operating times and are quite comfortable doing the procedure?
I think it's much easier. I think the learning curve is shorter compared with the HOLIP for the beginners to do the sodium. Dr. Liu,
The question that I will have would be,
I think it's much easier.
30 cases.
The learning curve
For
is
example, if you
shorter
come to
compared
Africa,
with the HOLIP.
Probably we have HOLIP in very small number of countries.
Dr. Liu,
Probably South Africa, Egypt, like the Mediterranean countries. 30 cases. Yeah. For example, if you come to Africa, they have the service. Probably we have 100% sure we don't have this service in Tanzania. Probably South Africa, Egypt, and like the Mediterranean countries. So, do you think if someone is able to have the service, that I'm 100% sure we don't have this service in Tanzania, the machine, Kenya, and you can learn the procedure and like if he gets mentorship from elsewhere, if someone is able to go, because it will be difficult for people to go abroad and come back, get practice, or he can learn the procedure. If he gets mentorship from elsewhere,
please.
remote mentorship, because
Please,
it will be difficult for people to go abroad and get practice or on-hand
Hello?
experience.
Hello, yeah. Dr. Kemper.
Doctor. Yeah. I have two questions.
Yeah.
The first one is regarding the irritative symptoms.
Hello, yeah.
Doctor. I use I have two questions.
Yeah.
I get in China. The first one is regarding the irritative symptoms. The drug license manufactured by LHH company in Beijing. And I'm pleased to see that technically the way they proceed then the same before the drug license manufactured by LHH company in Beijing. And I'm pleased to see that technically that the way symptoms are they proceed is the same. So I would like to know what is the frequency of low symptoms after the way coagulation is made and how. But in my experience with the laser, that irritative symptoms are very, very. I would like to have an idea of the. So I would like to know what is the frequency of irritative symptoms after this surgery and how you manage it. That's the first question. The second question, I would like to have an idea of the cost.
Computer mobile, we don't listen your second question clearly. Can you repeat it?
The second question is the cost of this equipment.
Computer mobile, we don't listen.
I think it depends on
second
the
question clearly.
insurance.
Can you repeat
In
it?
China,
The second question is
national
the cost of this equipment.
Insurance, yes, national insurance.
I think
So
it depends on the
only
insurance.
pay
In China,
$500
most
US
patients
dollars
have
by the
own
national
Insurance.
the situation
National
insurance. Yes,
insurance.
national insurance. So after that, they only maybe pay $500 US dollars by their own.
No, sir, not.
That is the situation in Shanghai. I don't know what in Tianjin is another city in Shanghai.
So, Dr. Sui, hi, Dr. Sui.
Yeah.
In Tianjin, Dr. Liu mentioned maybe
No, sir, not
3,000 to 5,000 RMB. Yeah, maybe similar around 500 to 700 US dollars. Yeah, in Tianjin, Dr. Liu mentioned after the insurance cover, 3,000 to 5,000 RMB.
Professors, and I think
maybe similar around 500 to 700 US dollars for patients after the insurance cover. Equipment, not for patients. Okay.
Professors, and I think Dr. Mobile company is Dr. Mobile. Yes, maybe you can take the question with Michael.
Equipment.
Yeah, the question with Michael.
Equipment, not for patients. Okay.
Sorry.
Save
the question with Michael. Dr. Mobile. Yes, maybe you can save the question with Michael. Michael and Cora can answer the question with Michael.
Sorry.
Save the question with Michael and Cora.
Okay, good.
机器多少钱不知道啊，
Michael
不是我买的。
Dr. Liu have no idea about the cost of the equipment. So, okay.
这个机器多少钱
Okay,
the staff of the routine will answer your question, Professor. Dr. Liu have no idea about the cost of the equipment.
Okay. And regarding the irritative symptoms.
Okay.
The
staff of the routine will answer your question, Professor, later after the meeting. 他这个这边的信号源听不见。
Okay. And regarding the irritative symptoms, let us read. What is your experience with?
没事，我这边能行。他这边的信号源听不见。
So I think
the operation is almost done, and Dr. Liu already processed the catheter into the patient.
So I think
it doesn't answer my first question.
The operation is almost done, and Dr. Liu already processed proceed the catheter into the patient. 第一个问题是什么来？
我也忘了。
It doesn't answer my first question.
那第一个问题是什么来？
我也忘了。WHS was a very excellent form about the BPH. So, Dr. Mobile, sorry, we forgot your first question. What's your first question? Was a very
it
excellent
was
form about the BPH.
The irritative symptoms
Dr. Mobile, sorry,
after these procedures.
We forgot your first question.
Experience of
What's your first question?
the operator, or what's your own experience and how you manage it? Because with in my experience with the diode laser, the irritative symptoms after these procedures, what's the experience of the operator, or what's your own experience and how you manage it? Because with in my experience with the diode laser, I have many patients complaining with that the experience sometimes contains anticholinergic drugs doesn't resolve the problem. In time before anticholinergic drugs, but experience what you can doesn't resolve the problem. It takes
I'm sorry. The connection is too bad. The connection is too bad. We didn't.
Experience.
The question is
what you
the
can
question
say.
is the diode laser that is using is
I'm sorry.
bringing
The connection is too bad. The connection is too bad.
urinary symptoms. So the question is asking what's your experience here? What is your thought? Is using is
so for the patient if
issues
they have
with irritative
incontinence,
urinary symptoms.
That's the question. Why
irritative symptoms, including emergency urge incontinence. What's your experience here? What is your thought?
So we maybe use for the patient if they have treatment incontinence, 1 or 2 months. That's the question. Why
irritative symptoms, including urgency urge incontinence.
Yes. Antagonist. So we maybe use some drugs, medical treatment, maybe for 1 or 2 months, such as the alpha. So I think our part, our part is closer. So maybe we move to another, the next part. I think it's prostatectomy, robotic prostatectomy.
Okay.
I will introduce. So I think our next part is closer. So maybe we move to the next part. I think it's prostatectomy.
Okay. Thank you very much for a good session.
I will introduce our next part, Dr. Zhang Mo from next part.
Okay. Thank you very much for a good session.
Thank you very much for the instruction from the Professor Cui Di. Shall we move forward to the next session? The floor is ready. Thank you very much for the instruction from the Professor Cui Di. Shall we move forward to the next session? The
后台我问一下，
for the surgery demonstration. 手术室准备好了吗？
手术室已经准备好了，然后院长已经在这个手术上。
后台我问一下，但是我们 but right now we can't see the。
您说。
手术室准备好了吗 ？Signal。
手术室已经准备好了，然后院长已经在这个手术上。张茂老师，要不然您先介绍一下这一个环节的参会人员，然后也给我们那个一个机会介绍一下病例，转到这个画面。
Okay, sure, no problem. So.
张茂老
Let's
师，
move
要不然
forward
您
to the
先介
next
绍一
session.
下
Good
那个这
morning
个
for
环
friends
节
in
的参会
Africa
人员，
and good
然后也给
afternoon
我
for
们那个一个
experts
机
in
会介绍一下
China.
病例。
And welcome again to the third CAUA surgery express on air. Let's move forward to the next session. Good morning for friends online meeting today, and good afternoon for experts in China for this session. Welcome again to the third CAUA Chinese urologist moderator. I think it's my great honor to join this online meeting today to perform surgery for his patient. Moderator for this session. I'm going to start another Chinese urologist moderator Winston, Professor Winston. I'm Jamo from the first hospital of China Medical University. On behalf of the organizing team, I would like to extend a warm welcome to all colleagues and friends joining us from China and Africa. I'm Jamo from the first hospital of China Medical University. In this session, on behalf of the organizing team, surgical demonstration of extend a warm welcome to all colleagues and friends joining us from China and Africa, presented by Professor Wang Yong. In this session, I think this is very important and highly refined of techniques in the management of localized prostate cancer, assisted radical prostatectomy, presented by Professor Wang Yong. I think this is very important and highly refined informative in the management of localized prostate cancer. Thank you again for being with us today. And now, we hope it's my pleasure to introduce today's surgeon, Professor Wang Yong, and inspiring for all participants. Thank you again for being with us today. We can see the slides. It's my pleasure to introduce today's surgeon, Professor Wang Yong. And we can see the slides. Introduction for the surgeon.
Please hang on a second. Yeah.
Okay. Already see the CV of Dean Wang Yong. And Professor Wang is from the second hospital of Tianjin Medical University, where he served as vice president of the hospital and head of prostate disease unit of Department of Urology. And Professor Wang is from the second hospital of minimally invasive surgical treatment, where he served as vice president of the hospital and head of prostate disease unit surgery department. So today's procedure is highly respected experts in the minimally invasive surgical treatment. I think compared with the conventional anterior approach, experience in robotic urologic surgery. So today's procedure is benefits in robotic recovery. We're very much looking forward with the conventional anterior approach, operative strategy, preserve the details and decision making may offer benefits in early continence recovery. We're very much looking forward to learning from Professor Wang's operative strategy will introduce details and decision making before the procedure. Okay, now the floor is yours. I believe there will be one. This Professor Wang Yong will introduce the case before the service starting.
Thank you, Dr. Wang, and thank you everyone. Good afternoon. This is Dr. from the department. So I will give you. Thank you, Dr. Wang, and thank you. It's a 61 years male, and from the department. So I will give you. Let's go to the case. It's a 61 years male, and his years, no others, and his no symptoms, and his and the ECT no symptoms, no others, and no symptoms, and his clinical exam no symptoms, and the ECT no symptoms, it's 67. Here. So, yeah, the biopsy so that the first patients is 4 biopsy, and there's 7 from the here. So, yeah, the biopsy so that then let's go to the Yeah, see. And, from the yeah, let's go to the yeah.
要看看是不是好像有。
Yeah.
邀请一下那个非洲专家现场。来，换真实。
Yeah.
No problem. So please show me the slides for introduction for professors.
来，
All right.
换真实。
Our moderator. So please show me the one of our moderator in this session is Professor Wensi Meng from the Tianjin Hospital. All right. One of the second hospital of Tianjin Medical University. He's right now he's our associate professor Wensi Meng from the supervisor Tianjin Hospital. From the second hospital of Tianjin Medical University, postdoctoral fellow in right now he's our associate professor, associate chief urologist, my best friend, doctoral supervisor, and he has experience of huge extensive fellow in Mayo Clinic RP, and also one of my best friends, Professor Meng, I think he do a great job in prostate cancer research. Has huge extensive experience on the RRP, and he also expert in other Africa. And I think he do a great job in prostate cancer
还可
research.
以来个
Let's
长
move
的听一下，先长的，
我们能
往外
切
拉一下。
换一下下一张。Let's move to the next expert from Africa. And why
还
can
可以
Professor
来个长
Dr.
的听一下，先长的，
我们
往外
能切
拉一下。
换一下下一张。Endoscopy Center, Cameroon. Right. His title is Doctor and current position and institution is urologist. Same from the same grade Endoscopy Center. I'm not sure the pronunciation is right or wrong. Right. Right. And title is Doctor and current position and institution is urologist. Cameroon. Same membership is. I'm not sure is also a member of the ICU and the Cameroon Urologic Association, Urology Center. In the term related professional responsibility and related academic interests and skills, and I think is also a member of ICU in the field of endourology, oncology, laparoscopy. In the term related professional responsibility and related academic interests and skills, and I think is expert in urology in the field of endourology, oncology, laparoscopy, all the three moderators in urology to host this session, pediatric urology expert. And welcome.
Thank you very much, Professor Tamo, and good afternoon, Camilo.
慢点。哎呀，你是这么大劲儿干啥？来。
Thank you very much, Professor Tamo, and good afternoon, Camilo.
慢点。哎呀，你是这么大劲儿干啥？来，刚才给他们慢一点，好吧？这个，哎，这干啥一下？干什么？准备一下。大这个啊。
Professor Camilo, can you hear us?
Yes. Do you hear me?
Yes, very clearly.
Okay. Nice to be there. Nice to thank you for the invitation.
Professor, thank you. Camilo, can you hear us? Nice to meet you.
Yes. Do you hear me? It's a pleasure.
Yes, very clearly.
Okay. Nice to be there. Nice to thank you for the invitation.
Thank you. Nice to meet you.
Me too.
Good
afternoon. It's a pleasure.
Dr. Zhang and Dr. Wen, and good morning, everyone from Africa.
Good morning.
And today, good afternoon, Professor Zhang and Wen will, and good morning, together will show from Africa. Protect me, for everyone. And today, Professor Zhang and Professor Wen will. With me together will show protect me 问我这个过程中啊，如果有什么问题的话，我没来得及解答，把它拿走。莫哥，你俩帮帮忙啊，好吧？
好的。
有时候跟他们需要来回的转换。问我这个过程中啊，莫哥，谢谢。问题的话，我没来得及解答。您和莫哥，你俩帮帮忙啊，好吧？
Excellent surgery.
有时候跟他们需要来回的
May I ask
转换。
what's the
莫哥，谢谢。
of this patient? I think the space is not very good.
BMI is about 20.
But may I ask what's the BMI of this patient? I think the space is not very good.
Very big. The BMI is about 20. But it's 20 challenge for me, I think.
Only 20. Oh.
I want to. But the可以 不要太使劲了。You can see the MRI. 来把膀胱往上吊吊。It's 换剪刀 challenge for me, I think.
You fix the colon to have more space?
可以
Yes,
OK.
I think so.
不要太使劲了。什么提一点，往上提一点。OK， 现在可以往上吊吊。换剪刀。
You fix the colon to have more space?
Today I
Yes,
want to
I think
show
so.
Yes.
什么提一点，往上提一点。OK， 现在可以差不多了。We can see here is the bladder. I pull the bladder. Good morning, everyone. Here and this today I want to show Douglas space posture. And here is the we can see here is the bladder. I pull the bladder. Here 你可以给大家介绍我做的过程中。Douglas space.
Okay.
And here is the seminar vessel. 温妮可以给大家
Good
介绍
afternoon,
我做的过程中。
Professor
Okay.
Simon. So my first question is, as we know, you also an expert in this kind of field. You perform a lot of risk-bearing robotic-assisted Professor radical Simon. prostatectomy. So my first question is the patient selection. As we know, you also an I'm not expert sure in this kind of field. You perform a lot of risk-bearing robotic-assisted radical prostatectomy. So my first question is the patient selection because the PSA value you noticed around 30 in the introduction for this patient per millimeter. Patients should be categorized into the image of MRI. The patient have a very huge PSA value is around 30. Can you briefly share your current criteria for selecting patients for the image of MRI? The patient have a very huge middle lobe. So anatomical or oncological factors share your current criteria for selecting patients for the risk-bearing approach. So in your practice,
Actually, at the beginning, we select like lower risk or the small prostate for this kind of technology, like Bojadi technology. At the beginning, we do the US variant prostatectomy, like lower risk. Actually, after we have done for this kind of surgery technology, like Bojadi technology, can to use this technology, including the huge prostate. But actually, after we have done is over 200, we found almost all the patients can for this use this technology, including the and even the biggest prostate, like locally advanced is over 200, including T3 or T4, even T4 kind of prostate. For the T4, we may have and even the like margin locally advanced prostate cancer, kind of including T3. For the T3, I think it's a perfect patient to do this. For the T4, we may have a problem to like margin prostate, like this kind of problem. So for the T3, I think it's a perfect patient to do this kind of surgery.
We'll find this the left last differential with and the seminal vascular. Here we can first left. We'll find for this the left protecting differential. And first we should to the seminal vascular. ureter maybe here left from this for the posterior outside about 1 centimeter. Protect me. So we first we should after this protect the I will the ureter upward maybe here. And this may be this a challenge for us outside about 1 centimeter. For the beginner, so maybe we and after this me from the I will the lens upward protect me. And this may be a challenge for us because all the stage for the beginner maybe we upward protect me from the anterior protect me. And the posterior we should and this process at all the stage the lens is upward. And this process. Okay.
Professor Serial Camado.
Yeah. Yeah.
I'm not sure. Do you use this kind of Bochati technology to dissect the prostate, or use Professor Serial Camado?
In fact, in Cameroon, we have many
I'm not sure.
advanced
Do you
or
use this kind of
prostate cancer.
Bochati
But sometimes
technology
when
to
it's possible, we can
dissect the
proceed
prostate,
some
or use
laparoscopic procedure.
regular?
So we have some. In fact, in Cameroon, we have many cases advanced or metastatic prostate cancer. But sometimes when it's possible, we can proceed some laparoscopic procedure. So we have some. It's possible
perform the risk-bearing radical prostatectomy using laparoscopic equipment.
Yeah.
So I think this will be very. Have you tried that before? Challenging to perform the risk-bearing radical prostatectomy using laparoscopic equipment.
The main challenge is the space, narrow
have you tried that before using?
We can see the prostate
it's too hard.
Too difficult. It's the
too difficult. Yeah. Too difficult. Yeah.
The main challenge is the space, narrow space. We know that from the past, we can see this NVB here and here. This is the past here. We release the NVB and to find we know that from the past capsule from a past. This NVB here and here, just like this. This we release the NVB and to some modified prostate capsule, 不是的 technology, just like this. This and we and here some modify the blood from the 不是的 technology. And just release the risk rate. And here we can see the blood vessel here. And we doesn't need just release the oil hemlock free risk rate. And we can see here is a prostate capsule.
So you are going to use intravascular way, right?
Yes, intravascular.
Yeah. And we can see here is a prostate capsule.
This is
so you are going to use intravascular way, right?
Yes, intravascular.
Yeah.
So artery.
And this is synovascular artery.
It's good for the T2.
So artery.
No clips at this moment.
This technology is
just cutting with the scissors.
It's good for
clip for the whole
T2.
surgery.
Yeah.
He's doing this kind of surgery. Yeah, no clips at all.
No clips at this moment. Just cutting with the scissors.
No clip for the whole surgery.
Yeah.
Blood vessel maybe we
should no clips at all.
Slowly. Is the prostate. The blood has a big blood vessel. Maybe we should slowly. Is a seminar vascular. Yeah. Okay. 谢谢啊。Okay. You can see just view this bladder. You can see just
if we do the regular surgery, we usually use the clip
压住，
overhead
压住，吸完了压住，让我看到血管，谁在上面？啊？
If we do the regular surgery, we usually use the clip
压住，
overhead
压住，吸完了压住，让我看到血管，谁在上面？啊？对，我在剪的地方，你吸完了一定要吸好，我要把那个血管给凝住的，好不好 ？Is okay. The left side. We have released just NVB here. We can see. Here we can see it's okay. And this is prostate. The left side. We have released just NVB. Okay, we use the same method to release the prostate right side. Just also from the pass. Okay, we use the same method to release the right side. Just also from the pass. This is the right side, the right cavity of the prostate. It's very clear. This is the right side, the right cavity of the prostate. And this technology also a big challenge for the robot.
Blood is not a problem to see exactly the
technology
plans.
Also a big challenge for the robot. 来这儿。
的意思是出血对看
blood is not a problem to see exactly the
影响不
plans.
大。We can see the clear 来这儿 anatomy.
的意思是出血对看前线有影响。
Very large. 影响不大。来，往上调。We can see the clear anatomy.
The professor Wang has replied there's no
very large.
There's no effect to see. Professor Cyril Kamado, robot Professor Wang has replied there's no.
等会儿下来了。
Okay.
There's no margin of prostate to see.
Okay. Thanks. Okay.
Because the length of definitely, in my opinion, the effect of magnification.
等会儿下来了。
Arms
okay.
robot has margin of prostate. Very powerful.
Okay.
So
thanks. Okay.
Great.
来，往上调。
Definitely, in my opinion, to operate because it's the arms laparoscopic surgery will be challenging or difficult to create space.
来，往上调。
Yeah.
A space to operate. But if it's transferred to laparoscopic surgery, it will be challenging or difficult to create. Professor Cyril, how many radical prostatectomy are you going to perform in every year? I mean, normally.
So I must say that I usually perform it with Dr. Njinu, who is one of my mentors, because in Cameroon we have many cases in laparoscopic surgery. So I must say that I usually perform it with Dr. Njinu, who is one of my mentors, because in Cameroon we have many cases in laparoscopic surgery. But one times we can perform per month for 2, 3 of prostatectomy.
Also common, just like in Europe and North America. Maybe just because the disparity.
Because as I told you, we have many cases of advanced prostate cancer.
Also common, just like in Europe and North
America. And then now it is the
severance. Because as I told you, we have many cases of advanced prostate cancer. So it's not.
I think this is the most difference between Professor Wang Yong and Bochiadi technology. I think he will keep the seminal vessel. I think this is the most difference between Professor Wang Yong and Bochiadi to this seminal vessel. I think he will keep the seminal vessel. Let's go. When Bochiadi do this kind of surgery, he will release this and come back to seminal vesicle at the first step and to release it.
Okay.
And the next step
when Bochiadi do this kind of surgery, he will release this seminal vesicle at the first step.
First on the blood neck, and the next step when may is also as the detail we want to do difficult for the beginner. First on the blood neck. Now we can see from the right side the blood here neck is seminal. So this right side on the left side. You can see the right side for the beginner vascular. Use this technology. No, this is the now we can see from the right side. Here is seminal. So this right side of the left side. You can see the right side. This is vascular. No, this is the NVB. 一会儿咱擦擦镜子啊。哦，看看这边。来到这儿。OK， 一会儿咱擦擦镜子啊。哦，看看这边。压下面。对，好。来挑上面。哦，压下面。对，好。来挑上面。哦，脏了，准备擦镜子啊，等会儿啊。把下面洗。挑这儿，看看。准备擦镜子啊，等会儿啊。好，把下面洗，擦镜子。小熊在台上是吧？在这儿。小熊，子豪你在啊？哦，我一子豪在上面。好，来擦镜子。And the next step will from the right side. 小熊在台上是吧？ And posterior. 小熊，子豪你在啊？哦，我一子豪在上面。Blood neck. And the next step will from the right side on the left side.
勇哥，我用中文说一句，看看你这个什么？我想提个问题，就是关于鉴定 blind neck identification of blind neck， 你有什么经验或者心得？勇哥，我用中文说一句，看看你
擦的镜子再擦一下，镜子脏了啊，跟张默
鉴定 blind neck
回答这个问题。这个主要还是
blind neck， 你有什么
左右和后
经验或者
主要还是原来既定的层次，发现的擦的镜子再擦一下，镜子脏了，就主要是推，不要随便去切，回答这个问题。把这个主要的推出来，特别是这个病儿，它是一个非常大的中叶。中叶的时候，我们主要还是害怕我们原来既定的层次，后面发现的这个左右层次推，就一定要沿着这个前列腺的表面去把这个膀胱颈给它推出来。把这个层次的推出来，特别是这个病儿，它是有非常大的中叶。中叶的时候，我们害怕水上到我们后面的输卵管口，来，我们就一定要沿着这个前列腺的表面去把这个膀胱颈给它推出来。主要是这个，它是有天然的层次的。
Actually, I heard Bochiadi Professor Zhang Mo he also asked the question is how to identify the red neck, left and right. Actually, I heard Bochiadi Professor he also said that this kind of question is close to the prostate and left and right, never too far left, right, from right to prostate, and because to protect the bladder itself.
Yes, just close to the prostate. This is the prostate. We can see.
Never too far from
very smooth
prostate, and because to
anatomical plane.
protect the bladder.
It's just close to the prostate. This is the prostate. We can see. It's very smooth. 往这边来。
Yes. Right anatomical plane.
哎，这儿。哎，往这边来。这地方就是这个这是 the huge prostate medium lobe。
Medium lobe.
这。
Okay, middle lobe.
这地方就是这个这是 that's the huge prostate medium lobe。
Medium lobe.
这。
Okay, middle lobe.
来这边。
Professor Wang Yong has excellent surgical technique, and I think he already found the right plane to move forward and to identify the location. Professor Wang Yong has excellent surgical technique, and I think he already found the right plane to
we can
move
see
forward and
the
to
prostate here.
identify the location
Just
for blind night.
close to the prostate. 来，调下来这儿。The surface. 对。We can see the prostate here. Just close to the prostate. Do it slowly here. The surface.
Do you use the balloon of a catheter to see exactly where is the bladder neck?
Slowly here.
No. Not use.
Generally, don't use it.
Okay. Do you use the balloon of a catheter to see exactly where is the bladder neck?
No. Not use. Because I think it's different from the anterior approach. Okay. If you retract the balloon, you can see more clearly to identify the blind neck. In the limited space, I think it's different from the anterior approach. If you retract the balloon, you can see more clearly to identify the blind neck. In the limited space,
怎么回事
not
？Yes, you're right. 来，这样，擦镜子，怎么回事？刚才 compared with anterior， 怎么回事？来，擦镜子，怎么回事？刚才？刚才是气腹的事儿，你可以稍微调大一点。好，可以。锁上镜子，刚才是气腹的事儿，镜子锁上，你可以稍微调大一点。好，可以，好，吸气进来，吸，然后调这儿，锁上镜子，吸，调这儿，镜子锁上，往上调，这是最难的地方。好，吸气进来。他们给我找了一个比较大的中线，调这儿。
Yes.
调这儿。往上调。
Exactly. This case
这是最难的地方。
Surgical challenge.
他们给我找了一个比较大的中线。
From the MRI image, the patient had very huge middle lobe of prostate. This case is surgical. It will be difficult to perform even from the MRI image approach. The patient had very huge middle lobe of prostate.
来，看看上面。
Actually, this is the biggest concern of this technology, Bojali technology. We are afraid to injure the urethra. Actually, this is the biggest concern of this technology. Actually, we cannot check Bojali during the surgery. We are afraid to the biggest problem. Injure the urethra. Actually, we cannot check it during the surgery. That's the biggest problem.
就术中中叶大的时候，怕损伤到输尿管口。
一点点来，对，从后面看不到。你看这个，一点点来，来调这儿。 现在还没有分到这个中叶的顶上，还得是爬山的过程。哎，这是
Professor Wang Yong said it's kind of like
现在还没有分到这个中叶的顶上，还得是爬山的过程。
Yeah.
哎，这是
Professor Wang Yong said it's kind
It's
of
very
like
challenging.
climbing the high mountain. It's now still to the top of the
来
mountain.
来，谢谢这儿。
Yeah.
好，
It's very challenging.
看我基本上都是在钝性的分离它。来，这就是找这个层次的一个注意的一个点。这个地方前列腺往前走，我基本上都是在钝性的分离它。这个地方是个很重要的一个拐角，找这个层次的一个注意的一个点。
So the Professor Wang Yong has said
这个地方是前列腺往前走的，所以这个地方是它突出的一个中叶。这个地方是个很重要的一个拐角。
He's keep pushing the bladder to create. The Professor Wang Yong has said the most important trick for this kind of surgery is
我看
blood dissection. He's keep pushing the bladder to create more clearly, okay, isolation.
我看 from here to see the medium lobe. This is based on the prostate.
Okay.
来，往上调。Here.
It seems like we are close to the apex of the medium lobe. 好像要到顶端了。
I think the bladder is open. I can see
It
the
seems like we are close to the
urine coming
apex of
out.
the medium lobe. 好像要到顶端了。
I think the bladder is
你说你见到
open.
尿液出来
I
了，
can see
要
the
挖开了。
对的，刚刚好像有左边这块有一点出来了。
可能我是从侧面把它打开了。我现在还是在从右边再把它分一分。你看，这都是大中叶，
你见到
这都是
出来了，要觉得要挖开了。
对的，刚刚好像有左边这块有一点出来了。
可能我是从侧面把它打开了。我现在还是这种大中叶都是右边再把它分一分。你看，这都是大中叶，这都是。因为这种大中叶都能是把它钝性都能分开的。
Wow. Wow.
And this is the blood.
Seems like the capsule prostate, right? We still can see the capsule. I mean the plane between
And
the
this is the
blind
blood.
leg and the prostate.
Yeah.
Like the capsule 是吧 prostate, right? We still can see the capsule. I mean the plane
它
between
只要
the
是
blind leg
不侵犯
and
膀胱颈的，
prostate.
我们一般的可以把它推出来。
是吧？
对。啊，它只要是不侵犯膀胱颈的，我们一般的可以把它推出来。
这个太 too big。
Yeah. Yeah.
来调整。这是 top。
Too big. Top of prostate. Okay.
Yeah.
Top of the mountain.
Yeah.
来调整。哦，这是 top。这
The top of
进去呢
prostate. Okay.
Top of the mountain.
Professor Wang Yong just said you must pay attention to avoid the
来
injury greater orifice.
Yes. Oh,
Professor Wang just said you must pay attention to avoid the injury. Greater orifice.
Yes. Now we can see the medium lobe. It's the medium lobe.
Almost coming out.
Now we can see the medium lobe. It's the medium lobe.
Almost coming out.
把尿管可以抽掉了啊。And there is the ureter.
这是 urethra， 这是尿道吗？
是的。看 And there is the 破了。I open the ureter. 来，往上调一下。
urethra， 这是尿道吗？
是的。Oh, this we can see the 这是尿道了，破了。
Caster.
Later. I open the ureter. 来，往上调一下。
Yes.
Yeah.
Wrong here. Oh, this we can see the
caster.
Later. Yes, the caster to protect the blood neck. The caster. 谢谢。
Excellent. Very challenging.
Professor Wang Yong, are you going to rebuild this bread neck?
To protect the blood neck. I think it's
very challenging.
It's fine.
It's not very big.
Professor Wang Yong, are you going to rebuild this bread neck? Because I think it's a little big.
那膀胱黏膜有一些脱出来。
Consider blood neck. I think it's
对，可能需要修整。
It's not very big.
膀颈
，OK，
膀口开的不大。
因为这个地方实际上都是相当于那个膀胱的那个泌尿肌这块有点缺失了，
脱出来，我不太
增生的前列腺把它给顶过来了。主要是黏膜，可能有一部分。
膀口开的不大。
膀胱肌口因为这个地方实际上都是相当于那个膀胱的那个从这块泌尿肌这块有点缺失了肌肉的，从这开始增生的前列腺把它给顶过来了，中叶上面主要是黏膜，可能有一部分，但这膀胱肌口还可以。来，你看，像你看从这块是有肌肉的，很明显有肌肉的，从这开始，来调这块就是附着在中叶上面的，调这。来，向西，好，来调这，要调这，来调这，哎，好好吸气，来，从侧面来。来调，吸着，调这儿，哎，调这，对，慢慢调气，好好吸气，来，从侧面来，吸着，哎，调这，对，慢慢调气。And the next is DVC. 调上面。对。
I have to say, when you perform this kind of surgery,
and the next is DVC.
Resistant. Good, very familiar with the operation. I have to say, when you perform this kind of surgery,
because you have to anticipate
you must have
all the steps.
A good resistant. Yes.
Very
familiar with the operation.
Yeah. Because you have to anticipate all the steps. Yeah.
Yes.
调，对，慢慢调来啊。哎，调这儿，对。哎，调这儿，对。And this interior of the prostate. We just also keep this surface of the prostate. to release the blood. We just also keep close to the surface of the prostate to release the blood. Okay, 左边，右边做左边，右边处理多一点，然后处理左边。OK，左边，右边做左边，右边处理多一点，然后处理左边。对，往上调，还是从这往上，从这调。这里对。对，往上调，还是从这往上，从这调。这里对。
Actually, I think Professor Wang Yong doesn't like it, the DVC usually. I have a question for Professor Zhang Mo and Kamado. Do you actually? I think Professor Wang Yong doesn't like it, the DVC usually technology. I have a question for Professor Zhang Mo and Kamado. Do you use? Do you like it, the DVC when you do this kind of surgery? Use the regular technology.
When you perform the IRP, you filter the DVC routinely. So we would like to hear, we would like the Professor Cyril Kamado to share your perspectives. My answer is when you perform the IRP, it's different from you filter the DVC the whole DVC. Right now, what I use in my surgery is my answer is now transverse. But can you understand now transverse? It's different from the 3O like the whole DVC. Right now, what I use in my surgery is now transverse. Can you understand now transverse? I use the 3O.
Not from left to right.
Vertical feature.
Yes.
Now because I think the advantage for that my surgery is avoid to injury the
not from left to right.
vertical feature. Also, I think the advantage for that my surgery is avoid to injury now. So I mean not going into so deep. If you using the vertical suture. Also can make the complete sphincter, which will be beneficial for the now so continence recovery after using the vertical suture. You can make the complete sphincter, which will be beneficial for the continence recovery after.
Because at the beginning we have three you can see the posterior and the right and the left side of a path. So the last step maybe is easier because at the beginning we have three posterior and the right and the left side of a path. So the last step maybe is easier for us. 在这儿，吸这儿。下面洗，洗这儿，洗这儿。我看不见，等会儿，你先回来，先回来。哦，等会儿我们两个打架了。在这儿，洗这儿，下面洗。对，我看不见，等会儿，你先回来，先回来。对，对。
Is this the UHR?
Yeah.
Yeah, okay.
Is that cancer? 哎，对
This is the urethra? Receiver catheter.
，Yeah.
Yeah, okay.
Is that cancer?
Yes, receiver catheter. Wow.
We dissection the prostate.
Yeah.
Oh, wow, it's huge.
Yeah.
Prostate.
And then we can see the
Wow.
we dissection the prostate. Medium lobe.
Yeah.
Okay. Wow, it's huge.
Okay, that's
prostate.
等会儿 we can see the seminal and the medium 没有什么出血，可以。
OK。
来查镜子吧。OK， that's 下一步我们就比较简单了，就是缝合了。出血。哎呀，等会儿我先看看。
我觉得时间还是很快的。
没有什么出血，我们可以准备下台，下台时候下一步我们就比较简单了，就是缝合了。哎，我这口罩有点热，刚才有点哈气。
我觉得时间还是很快的。
我们可以准备下台，下台时候。
How many cases for RRP?
哎，我这口罩有点热，刚才有点哈气。
Are you going to perform in area around 500? So among normally.
You mean the time?
Neo center. How many cases for RRP?
How many
surgeries of RRP are you going to perform in area
for this
around
year
500?
Or for me? You mean the time?
For your whole center.
Actually, it's like 500 a year.
Okay.
For this year or for me?
And for the learning curve, how many cases have you to be performed before
like
the course?
500
I suppose
a year.
it's not for beginners.
Okay. 司望他问你说
And for the learning curve, how many
对于
cases
新手
have
来
you
讲
to
做多少
be
题能
performed
掌握
before
这
the
个
course? I suppose
Actually,
it's
we
not for
did
beginners.
this kind of study. Actually,
司望他问你
mostly
说
use like
水曲线
30
对
cases.
于新手来讲
30
做多少
cases,
题
okay.
能掌握这个
Actually, we did
把尿管往里来
this
点。
kind of study.
Now we can see
mostly use
the
like
right,
30
the left.
cases.
The white is
30 cases,
capital
okay.
prostate
30
and the white
cases.
blood vessel. We 把尿管往里来点。We could see the fat. Now we can see from here and the right, the left. The white is capital prostate and the white blood vessel. We 好了，没什么出血啊。We couldn't see the fat.
很好啊，真的很好。
from here
这个
and
得一切除之后，
切除之后它就不会出血了。来，我看看膀胱颈来。没什么出血啊。哎呦，
很好啊，真的很好。这个得一切除之后，
缩回去了。来切除之后它就不会出血了。吸前面。来，我看看膀胱颈出血好像。动脉。哎呦，我看看膀胱颈在哪？有时候膀胱颈不好找，缩回去了。缝合的时候，来吸这儿。这是膀胱颈啊，吸前面。你看，这尿出的很好，只要尿出的好，我们就不害怕。我看看膀胱颈在哪？有时候膀胱颈不好找了。
If we can see the urine，
这是膀胱颈啊。
We don't need to worry。
这尿出的很好，只要尿出的好，我们就不害怕。
Ureter orifice。
来，给我串针尺还有线。什么线？什么线
？We don't need to worry about the injury。
行。
Ureter orifice。
来，给我串针尺还有线。是什么线
？Going to stick the
什么线
rednate
and
the ureter with 30 ulock vlock.
Vlock, okay.
Yeah, vlock. It's going to stick the rednate and the ureter with 30 vlock.
Yeah.
Vlock, okay.
Yeah, vlock.
From 1 o'clock. Yeah. We do it from 1 o'clock. Here I see. From 1 o'clock. Here. Is a flat.哎，慢点儿，吸的慢一点啊。哎，慢点儿，吸的慢一点啊。哎，走，哦。哎，走，哦。对，别着急，你把我的线给我扯走了。对，别着急，你把我的线给我扯走了。This second maybe the 12 o'clock. This second maybe the 12 o'clock. 走，尿管儿，尿管儿，慢点，进来一下。走，OK。走，尿管儿，尿管儿，慢点，进来一下。走，OK。
How many stitch do you put?
Oh.
Excuse me.
How many stitch do you put?
他说他缝多少针，就是吻合这尿道。How many stitches, right?
Excuse me.
6 to 8.
Didn't hear your question.
I think
6
6到8针。
Okay.
Yeah.
他说
It
他缝多
depends.
少针，就是吻
Has
合这
the
尿道。
bread
How many stitches,
size
right?
and the
6 to 8. Actually, I think
6
6到8针。
8. Okay.
Yeah.
Six,
I think it's
it
enough.
depends. Has the bread size
Yes.
and the
Actually, 6 to 8. I think it's
Okay.
enough.
Okay.
针头窝了是吧？ 这针是处理过了是吧？好，非常好，看就是老手，针可窝了是吧？这针是处理过了是吧？好，非常好，看就是老手。好，两管进来，来。And then I put the catheter to the blood. 哦，OK，好，两管进来，来，好，往里走。哦，可以了，可以了，可以了，好了，好了，好了，好了，catheter to the blood。好，把下面的尿吸吸。血尿。哦，OK，好，往里走。哦，可以了，可以了，可以了，好了，好了，好了，好了。好，把下面的尿吸吸。血尿。这地方有点出血。这地方有点出血。现在就开始缝的是后臂。现在就开始缝的是后臂。对，缝一针插他镜子啊。这是我今天一共就转播4场是吧？来插的镜，插的镜。
应该后面还有吧？
还有2场，还有一个结石。这是我今天一共就转播4场是吧？都在这个不在这屋吧？来插的镜，插的镜。可以准备了，下一个
后面还有吧？
还有2场，还有一个结石，中间太大了，前列腺可以，都在这个不在这屋吧？插好镜了吗？可以准备了，下一个我们这个马上结束了。中间太大了，前列腺可以。看可以，这个插好镜了吗？比较瘦。哎，细点来，细这看哪出血，细上面，来这儿看看哪出血，细这，看可以，这个人比较瘦，这儿，可以哈，哎，细点来，细这看哪出血，细上面，来这儿看看哪出血，细这，这儿，可以哈。把尿管拔掉吧。把那个把膀胱往下稍微放一下。好，我这边马上就结束了。把那个把膀胱往下稍微放一下，我这膀胱放了吗？ 大家稍微来点，我这边马上就结束了。啊，好，来问，放这边基本缝完了，你稍微我这膀胱放一下就结束了，去那边准备那摊吧。稍微来点，我把这个紧一紧。来，谢谢了，好。
I think this surgery is over, and thanks very much for Professor Wang Yong wonderful surgery with Bochadi technology. And thank you. I think this surgery is over, and thanks very much for Professor Wang Yong giving this wonderful surgery. I don't know whether Bochadi technology.
This is the right pronunciation.
Thank you very much. Serial, 可不可以跟你说两句吗？ I don't know whether Professor.
This is the right pronunciation.
Excellent surgical demonstration.
Thank you very much.
For sharing your perspective. Thank you, Professor Wong. Looking forward to see you excellent surgical demonstration and welcome to join our CAUA for sharing valuable perspective from clinical practice. And looking forward to see you.
Okay, see you. Bye-bye.
And welcome to join
好，谢谢大家。好了，那个转播可以切完了。好，我们就做完了啊。Okay, thanks.
Thank you. See you.
Okay, see you. Bye-bye.
可以去陈医主任那边了。
辛苦了，勇哥，拜拜。
好，谢谢大家。好了，那个转播可以切完了。啊，我们再准备一根这个线给我吧，好吧？可以去陈医主任那边了。
不放它，放那个新的。
哎，再准备一根这个线给我吧，好吧？没有。对。来，把这个可以。
不放它，放那个。
拿走。真没有。好。来，把这个可以。好，拿走。哎，这个出血。真滋滋的。好。好。哎，这个出血。看看，滋滋的。
Professor Cyril and Professor
没有
Remiges.
来把
Dr. Cyril and Dr. Remiges. Can you hear my voice? Professor Cyril and Professor
没有
Remiges. Yes, very clear.
来把
Dr. Cyril and Dr. Remiges. Can you hear my voice? Now the third session, the surgery is going to start.
来，
Dr. Remiges, could you please introduce yourself to all of us?
Okay, thank you everyone.
Now the third session, the surgery is going to start.
Dr.
Remiges, could you please introduce yourself to all of us?
In West Africa.
Okay,
yes,
thank you everyone.
You introduced me. My name is Dr. Remiges.
Yes, I'm aware that it's afternoon in China and I'm a urologist working at
still morning in East Africa and morning in
Dodoma
in West Africa.
Tanzania.
Yes,
and I have a working experience
you
of
introduced me. My name is Dr. Remiges and
13 years old.
13 years.
I'm a urologist working at Benjamin Mkapa.
I've been
Dodoma,
working with my colleague
Tanzania.
And
I have a working experience of
I'm interested with
13 years old,
13 years
and innovation which is happening in urology.
I've been working with my colleague.
Yes, thank you, Dr. Remiges. And I think we still have the co-chair, co-moderate, Dr. Cyril. Dr. Cyril, are you still here?
Thank you.
Yes, thank you, Dr. Remiges. And I think we still have the co-chair, co-moderate, Dr. Cyril. Okay, maybe he had something special. And at this session, the Professor Liu Chunyu will introduce us the radiant shielding laser lithotripsy. And Professor Dr. Remiges, could you please introduce Professor at this session, the Professor Liu Chunyu. And can you see the introduce us the radiant shielding laser lithotripsy. And Professor Dr. Remiges, could you please introduce Professor Liu Chunyu to all of us as well? Professor Liu Chunyu, and can you see the CV of him?
Okay, I'm opening up.
Can you see the CV of Professor Liu Chunyu?
Sure. Okay, I'm opening up. So I'm opening up. So the delay here is everyone on board? Sure. So I'm opening up. So the delay here is everyone on board?
Yeah, Professor Remiges, could you please introduce a little bit of Professor Liu Chunyu? He's the surgeon today.
Yeah, I'm trying to check.
Yeah, Professor Remiges, could you please introduce a little bit of Professor Liu
with the
Chunyu?
video
He's
here,
the surgeon today.
but I can I'm trying to check. I'm not connected to the 1 minute and sure with the video here, but I can definitely introduce him. May I have 1 minute and the introduction, yeah. Sure, I'm going to give a proper introduction, yeah. So, okay. Is everyone on board? Yeah. I'm going to introduce Dr. Wang Jialong. So, okay. Is everyone on board? Yeah.
Dr.
I'm going
Remiges, Professor
to
Wang
introduce
Jianlong is
Dr.
not here right now. We
Jialong.
need to wait him for like seconds. And at this moment, maybe you can introduce Professor Liu Chunyu, the surgeon of today. Dr. Remiges, Professor Wang Jianlong is not here right now. We need to wait him for like seconds. Can you see and at this moment, the CV of Liu Chunyu, Professor Liu Chunyu, the surgeon of today, who will perform the laser lithotripsy surgery to all of us. Can you see his CV, the CV of Liu Chunyu, Professor Liu Chunyu? Okay, and I see Professor Wang Jianlong is already online. Professor Wang Jianlong, can you hear my voice?
Yes, I can.
So great. Could you please have us do a little bit introduce? Okay, and I see Professor Wang Jianlong is already online. Professor Wang Jianlong,
Okay.
can you hear my voice?
Hello, everyone.
Yes,
it's my pleasure to
so great.
introduce
could you please have us
Professor Liu
do a little
Chunyu, the
bit
second
introduce
hospital
to
of Tianjin Medical
Professor
University,
Liu
China.
Chunyu, the surgeon today?
Okay. Hello, everyone. I'm very glad it's my pleasure to introduce Professor Liu Chunyu, the second hospital of Tianjin Medical University, China, and to introduce Professor Liu. I'm very glad today Professor Liu will show us accept the lithotripsy surgery, CAUA surgery express on air, and now to introduce Professor Liu can introduce the case today. Professor Liu will show us lithotripsy surgery.
Hey everyone. Okay. This is Dr. An from the Department of Urology, the second hospital of Tianjin Medical University. For this surgery, I'm the assistant of Dr. Liu. And please let me introduce this surgery. This is everyone. Okay. This is Dr. An from the Department of Urology, the second hospital of Tianjin Medical University. For this surgery, I'm the assistant of Dr. Liu. The information of this patient is please let me introduce this surgery. This is female and the height of the height of her is ureteroscopic 160 centimeters, and the weight is 50 this information of this patient is her BMI is 19.53 years. So this patient's chip content is left side. The height of her is flank pan for over 160 centimeters, and the weight is past history 50 so this patient and only her BMI is 19.53. And so this patient's chief content is left side flank pan associated for over 2 minutes, and vomiting. Let's go quickly go through this patient's accompanied by fever. So this maximum body temperature only have twice ESWL, and the symptom of her is And after the examination with the NAJA and the clinical examination, also according to the CT, the maximum body temperature in the left upper ureter. And the HU parameter is degree 1,266. And after the examination, the size of the stone clinical examination 1.1 centimeter. According to the CT, the calculus in the left upper ureter. And her blood HU parameter is white blood cell 1,266. And the urine, so the size according to the urine test, the white blood cell is negative, the red blood cell is 0.6. Also the urine culture and her blood test. Let's move to her within the normal limit. CT and the urine. The CT examination is easily to the white blood cell is negative. The red blood cell is calculus is in the left the urine culture is negative. And the HU parameter is. So let's move to her 1.1 multiplied. The CT examination is easily to the calculus the camera to the left upper ureter. And the HU parameter is.
Good afternoon, everyone. We will perform our surgery. It's urolithotripsy.
Let's switch the camera to Dr. Liu.
Just now we had a look with the everyone. We will perform our surgery. The stone is in the upper urolithotripsy. We just now we stone had a look with the radial ureter pelvic. And now the stone is in the upper ureter. Get where? Now we will put the stone from the ureter to the renal pelvic. And now we also plan a fence, flexible and navigable, put the US through the face. Get where? It is 11. US we use 13 French. Is a fence, flexible and navigable, and section sheath. It is 11, 13 French. There are little structure maybe in the stone position. No.
Hello, Professor Liu.
Yeah, 建龙好，建龙。The little structure maybe in the stone
lithotripsy. You know,
position.
Before the surgery, we can't. Hello, Professor Liu. How the condition? So we can't be through lithotripsy. You know, we can do before the surgery. We can't stone. Can you how the urethral condition? How to so make sure we can restore condition for this patient. We can do the this for the stone. Can you how to make sure the urethral condition for this patient?
Yeah. 一般我们的是这样，就是这个一个是刚才原来咱们讲那几条有过历史的，有手术历史的，排过结石的，这个是这样。还有一个就是我们用不同的这个就是鞘，这个我常规用的是一个是刚才原来咱们讲那几条还有过历史的，做手术历史的。如果我们有排过结石的做的话，大概我们得90%以上的。结石都没有。是这样，还有一个就是我们用不同的这个配一个细鞘，因为我现在我常规用的是11-3嘛，刚才也讲，就是我们现在还有就是10根12。如果我们有10根12做的话，大概我们得90%以上的结石都没有。会配一个细镜的。现在我今天用的是一个8.5的。Here is a stone， 就是我们现在基彩的镜。We pushed it from the upper ureter. Now we will use the reconciliation laser. Yeah, as a parameter. Left side is from the upper ureter. 0.3 G and frequency is 100. Now we will use the right side is reconciliation laser. Yeah, 2 as a parameter. G and left side is 0.3 15 G and frequency is 100. The right side is 2 G and 15 frequency. Yeah. The advantage of stellium laser is to do the lithotripsy is no movement and no bleeding. The advantage of thulium laser is to do the lithotripsy is no movement and no bleeding compared with helium laser. OK， 试你左脚吧。Now we use the left side. 0.3. OK. G and 100 frequency. Now we use the left side. Calcium oxalate 0.3 monohydrate. 0.3 very hard. G and 100 frequency. This stone should be calcium oxalate monohydrate. Always very calcium hard. Oxalate monohydrate. We always use the fragment method. That thing is not good. Always calcium oxalate monohydrate. We always use the fragment method. That thing is not good. 准备去吧，我这个估计一会儿就完了。你们准备去吧，我这个估计一会儿就完了。这不是一会儿10分钟就完了，还说半小时呢。对呀，这，你们准备这些事儿。这没人理我，现在我是吧？也没人有问题啊。一会儿10分钟就完了。没人问的，还说半小时。
Hello, anyone online?
对呀，你们准备这些事儿。
我这是开着的是吧？
这没人理我，现在我是吧？也没人有问题啊，没人问的。
Hello, anyone online? Is there any question? 哦，我这是开着的是吧？哦。
这激光也太，怎么感觉这激光劲儿比咱大多了？
哦 ，OK。
啊，一水的吗？有激光不怕的，一水太就是越硬，怎么感觉这激光劲儿比咱大多了？
哦 ，OK。
啊，一水的吗
？Hi, doctors. Is there any question?
有激光不怕的，一水，就是越硬它越。
You are a mute. Hi, doctors. Is there any question? Okay, you are a mute. OK， 介绍一下主任。
把水压调大点，水压调大点，水压调大点。这样你走石头。
我刚才。啊 ，Hi, Dr. Mute. So
对。把水压调大点，水压调大点。
Hi, Dr. Mute.
水压调大点。
Do you have any experience to share with us? Hi, Dr. Mute. So
对。
So in your country, do you pre-put the intent into the ureter before the surgery? Do you have any experience to share with us?
Yes. Yeah.
So in your country, do you pre-put the intent into the ureter before the surgery or not?
Because I cannot see it clearly what is happening, but some patients we do pre-stent. Yes. And we have some patients. I've been out of the stone, but at the same time, for a while, they have a previous history of psoriasis. What is happening? But as you can see, is some patients we do pre-stent, and we have some patients having a stone, but at the same time, they have a previous history of severe inflammation, and as you can see, it's difficult sometimes to prefer sometimes to do pre-stenting, and then so with severe inflammation and after 2 weeks to 6 weeks, that's when we go back and we do prefer sometimes to do pre-stenting.
Sounds great. It's similar. We also do the pre-intent of around 2 weeks.
After two weeks
And
to 6 weeks,
how about the 2 weeks to
estimate
about the patient's situation before the surgery to avoid the? It's similar. We also do the pre-intent of around 2 weeks infection. And how about the estimate about the patient's situation before the surgery to avoid the
and the urine curtain sensitivity, because we know with stasis of urine, sometimes they usually get urine tract infection. For every patient, we usually then we check urinalysis, also we do electrolyte and the urine curtain sensitivity, because we know with stasis of urine, sometimes they usually get. So we do all the pre-op tract infection preparation, including the check, assessing also the electrolyte on the age of the patient.
Okay.
So we do the CT scan, ultrasound. So we do all the more than 50 years preparation, including the echo, assessing the heart. So depending on the age of the patient. And the idea of the patient, so if the patient is more than 50 years, we do ECG and the echo, the stone, the heart. And the idea of the patient, kidney stones, because of the pain, sometimes they usually come with elevated blood pressure, and after operation, sometimes the blood pressure settle. I think down. Because of we came to realize that kidney stones, because of the pain, sometimes they usually come with because of the pain due to the elevated blood pressure, and after operation.
So is the urine culture very necessary for each patient in your hospital before the surgery?
Because of the pain. Because of the pain due to the kidney stones. Not all, unless we see something.
So is the urine culture very necessary for each patient in your hospital before the surgery?
There's a preclinical condition like fever. Not all, unless we see something, unless we see that the analysis and we see the leukocyte condition, and there's a preclinical condition like fever, imitates but the urine tract infection, not for the patient, unless we see that the infection really condition after operation. And we are using holmium laser rather than thallium, so we see retrofashion and urine tract infection. Sometimes we don't want to get infection after operation.
So the situation in China is that there will be more and more lithotripsy surgery and less PCR. So we are curious about what the situation in Africa. So the situation in China is also maintained there will be more and more in the lithotripsy surgery and less PCR. So we are curious about what the situation in Africa. So the PCR surgery also maintained
Professor Liu, can you introduce the advantage of this recurrent laser? We know it's a good weapon for the lithotripsy.
Yeah.
Professor Liu, can you introduce the advantage of this recurrent laser? We know it's a good weapon for the lithotripsy.
Of the no bleeding. The first one should be first no movement with cerium laser. Is better for the cerium laser. The second one is oxalate calcium of the no bleeding. This stone should be for the calcium oxalate hard stone monohydrate. It's better for the mono. Always this stone is very hard for oxalate calcium. This stone is calcium oxalate monohydrate. Always this stone is very hard for oleum. Now we will finish. Yeah. Please. Yeah.
Please, I have one question. So good afternoon, everyone, and good morning to Africa people here. So I wanted to know which kind of anesthesia do you use mostly here for this procedure? Is it a general anesthesia or Africa people here? So I wanted to know which kind of anesthesia you use. What kind of anesthesia that you use for this procedure? Is it a general anesthesia or
Professor Wang?
Laser? Yeah.
What kind of what?
What kind of
anesthesia? Which kind of anesthesia do you use? Yeah.
Cilium, Holium. Most
Professor Wang?
Laser? Yeah.
What kind of what?
Anesthesia?
What kind of
Anesthesia. Which kind of anesthesia do you use?
什么麻醉？什么？
Cilium, general anesthesia. Yeah. Most sometimes local.
But the anesthesia. Sometimes you use local anesthesia.
用什么麻醉？什么麻醉？
general small anesthesia or simple procedure. We sometimes local. Our special person.
Sometimes you use local
like the pregnancy patient. We will use the local. The small or simple procedure. We use local.
Thank you.
Use our special person, like the pregnancy patient. We will use the local. Finished our anesthesia surgery.
Most patients use the general anesthesia. Thank you.
Yeah. We will have a check of the ureter. If there are any finished stone left or damage or structure of the ureter. We will have a check of the ureter. If there are any stone left or damage or structure of the ureter. We will check the ureter. We will check the ureter. Here is the stone bed. Little blobs. Here is the stone bed. Little blobs. Okay, no current damage of the ureter. We will plant the ureter stent. Okay, no current damage of the ureter. We will plant the ureter stent. 不行，就用咱这招，我们要用那个软镜推嘛。现在我们这一套自己都，你这人不在，我们又老到不一样的地儿。左边不行，就用咱这招，我们要用那个左边软镜推嘛。现在我们这一套自己都，你这人不在，我们又老到不一样的地儿。左边，右边，左边。那中间有个尖弯的，老给你从侧面出来。等会儿别着急，过来，行，走吧。那中间有个尖弯的，老给你从住了啊，别再出现这问题了。等会儿别着急，过来，行，走吧。有穿镜子，穿镜子。还给理直住了啊，别再出现这问题了。有穿镜子，还给理直了，扒拉你知道。一定站住。 你看又补个灯柱，对。灯柱打死，一定灯柱。你看又补个灯柱，对，又玩了啊，快走吧。又玩了啊，快走吧。跳，221圈嘛。Okay.
Yeah, the position of the stand is perfect. Thank you, Dr. Liu. Hi, Dr. Wang. Could you have give us a final summarize? Thank you.
Okay. Now I think Professor Liu have a good technology for the lithotripsy,
Hi,
and
Dr. Wang. Could you have
it's a
give
very
us
good
a
show
final
for
summarize?
us.
Thank you.
Very glad to have this survey. Now Thank you. I think the
Thank you, Dr.
Professor
Wang.
Liu
Thank you,
have a good technology for the
everyone.
lithotripsy, and it's a very good show for us. Very glad to have this survey. Thank you.
Thank you, Dr. Wang. Thank you, everyone.
Thank you.
没事。
From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been raising against time. From China's fertile lands to the boundless skill in their hands and duty in their heart. They kindle of Chinese and African healers have been raising against time for preserving synergize medical expertise with skill and their experience and duty in their heart. Fruitful collaboration. They kindle communities across the land wherever they go. From the foundational pillars of urology to the synergize medical expertise of minimally invasive surgeries, bringing fruitful collaboration from spreading health awareness across the land to co-training future talent. From the foundational pillars of urology, China Africa exploration is taking minimally invasive surgeries out across the continent. From spreading health awareness to co-training future talent, shared steps and shared struggles. China Africa wisdom of medical is taking root, grows ever branching out across the continent. Each white-coated healer rise anew. The timeless shared steps and shared struggles knows no borders. The journey of medical every cross-border grows ever richer. Echoes the noble calling. Each white-coated healer rise anew. The timeless truth, clothed in health knows no borders. We become the light. Every cross-border endeavor shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. In white, to be the light, to empower life. Together, we shine toward the dawn. May the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been raising against time. From China's fertile lands to the boundless skill in their hands savanna and duty in their heart. They kindle of Chinese and African healers have been raising against time for preserving synergize medical expertise with skill and their experience and duty in their heart. Fruitful collaboration. They kindle communities across the land wherever they go. From the foundational pillars of urology to the synergize medical expertise of minimally invasive surgeries, bringing fruitful collaboration from spreading health awareness across the land to co-training future talent. From the foundational pillars of urology, China Africa exploration is taking minimally invasive surgeries out across the continent. From spreading health awareness to co-training future talent. Through shared steps and shared struggles, China Africa wisdom of medical is taking root, grows ever branching out across the continent. Each white-coated healer rise anew. The timeless shared steps and shared struggles knows no borders. The journey of medical every cross-border grows ever richer. Echoes the noble calling. Each white-coated healer rise anew. The timeless truth, clothed in white, knows no borders. We become the light. Every cross-border endeavor shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. White, to be the light, to empower life. Together, we shine toward the dawn. May the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been raising against time. From China's fertile lands to the boundless skill in their hands savanna and duty in their heart. They kindle of Chinese and African healers have been raising against time for preserving synergize medical expertise with skill and their experience and duty in their heart. Fruitful collaboration. They kindle communities across the land wherever they go. From the foundational pillars of urology We synergize medical expertise of minimally invasive surgeries, bringing fruitful collaboration from spreading health awareness across the land to co-training future talent from the foundational pillars of urology. China-Africa exploration is taking minimally invasive surgeries out across the continent from spreading health awareness to co-training future talents through shared steps and shared struggles. China-Africa wisdom of medical is taking root, grows ever branching out across the continent. Each white-coated healer rise anew. The timeless through shared steps and shared struggles knows no borders. The journey of medical every cross-border grows ever richer. Echoes the noble calling. Each white-coated healer rise anew. The timeless truth, clothed in white, knows no we become the light. Every cross-border into shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. In white, to we be the light, to empower life. Together, we shine toward the dawn. May the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time from China's fertile lands to the boundless African savanna. Duty and their heart. Waves of Chinese and African healers have been racing against time for preserving life. We synergize medical expertise with skill and their experience and duty in their heart. Fruitful collaboration. They can do communities across the land wherever they go. From the foundational pillars of urology. We synergize medical expertise of minimally invasive surgeries, bringing fruitful collaboration from spreading health awareness across the land to co-training future talent from the foundational pillars of urology. China-Africa exploration is taking minimally invasive surgeries out across the continent from spreading health awareness to co-training future talents through shared steps and shared struggles. China-Africa wisdom of medical is taking root, grows ever branching out across the continent. Each white-coated healer rise anew. The timeless through shared steps and shared struggles knows no borders. The journey of medical every cross-border grows ever richer. Echoes the noble calling. Each white-coated healer rise anew. The timeless truth, clothed in white, knows no we become borders. The light. Every cross-border into shine toward the dawn. Echoes the noble calling. May the friendship between China and Africa bloom in every corner of the world. In white, to be the light, to empower life. Together, we shine toward the dawn. May the friendship between China and Africa bloom in every corner of the world. To be the light, to empower life. And now, the light had set sail. From China's fertile lands to the boundless African savanna. Waves of Chinese and African healers have been racing against time from China's fertile lands to the boundless African savanna. Duty and their heart. Waves of Chinese and African healers have been racing against time for preserving life. We synergize medical expertise with skill and their experience and duty in their heart. Fruitful collaboration. They can do communities across the land wherever they go. From the foundational pillars of urology. We synergize medical expertise of minimally invasive surgeries, bringing fruitful collaboration from spreading health awareness across the land to co-training future talent from the foundational pillars of urology. China-Africa exploration is taking minimally invasive surgeries out across the continent from spreading health awareness to co-training future talent through shared steps and shared struggles. China-Africa wisdom of medical is taking root, grows ever branching out across the continent. Each white-coated healer rise anew. The timeless through shared steps and shared struggles knows no borders. The journey of medical every cross-border grows ever richer, echoes the noble calling. Each white-coated healer rises anew. The timeless truth, clothed in health, knows we become the light. Every cross-border into shine toward the dawn, echoes the noble calling. May the friendship between China and Africa bloom in every corner, clothed in white. We become the light. Together, we shine toward the dawn. May the friendship between China and Africa bloom in every corner of the world.
Professor Besser.
Yes, I'm here.
Yes, can you hear my voice, right? You can hear my voice. And could you please introduce the moderator, like introduce yourself to all of us, and then tell us something about research. Can you hear my voice, right? You can hear my voice. And could you please introduce the moderator, like introduce yourself to all of us, and then tell us something about the surgeon.
Hello.
Yeah, we can hear that. Great, we can hear you.
So, I'm Dr. Berte from Bamako. I'm working in Pointe Teaching Hospital.
Yeah, we can hear that. Great, we can hear you.
So, I'm Dr. Berte from Bamako. I'm working in Pointe Teaching Hospital.
Thank you, Professor. And I think maybe you can introduce a little bit of our surgeon today, Professor Hu Hailong. Can you see the CV of him? Thank you, Professor. And I think maybe you can introduce a little bit of our surgeon today. Have you already seen the CV? Can you see the CV of him? Have you already seen the CV? Professor, you are on mute. Please, you need to unmute yourself.
Yes, sorry.
Okay.
So Professor Yu Hailong is
Professor, you are
working
on
in the
mute.
second hospital of Tianjin Medical University, China.
You need to unmute
He's a chief
yourself.
urologist and associate professor.
Yes,
Sorry, Dr. Supervisor, deputy director, so Professor Yu Hailong laboratory, working in the second hospital of Tianjin Medical University, China. Administrative department of urology, the second hospital of Tianjin Medical University. Deputy director, is a director of engineering laboratory center, Tianjin Institute of Urology of Tianjin Medical University. Is Administrative Department of Urology, the second hospital of Tianjin Medical University. Is the director of Clinical Chinese Association of Integrative Medicine. Hospital of Tianjin is a member of Clinical Research Group. Is chairman Urology Committee of Chinese Medical Association. Integrative Medicine, Youth Editorial Board Urology Committee, Chinese Association of Integrative Medicine, Chinese Journal of Urology. He is a member of Clinical Research Member Urology Committee of Chinese Medical Doctor Association. He is also Vice Editorial Board Member, Planning Urology Quality Control Center. He is Chinese Journal of Primary Research Standing Committee member on Urology Epigenetic Regulation, Tumor Association, Microenvironment Modulation. He is also Vice President and Personalized Urology Quality Control Center. Medicine in Blood Cancer. Also Primary Research Interest Focus on epigenetic regulation, tumor studies, so microenvironment modulation, doctor, and personalized precision medicine in bladder cancer as principal investigator.
Thank you, Professor Besser. And I think we will have someone, Professor An, Dr. An from the second medical affiliate of Tianjin Medical School, and to introduce the the place. Thank you, Prof. Besson, and I think we will have someone, Professor An.
Hello, everyone.
Dr. An from
welcome to Dr.
the
Hu
Second
Hailong's
Medical
we
of
are
Tianjin
on
Medical
live
School,
surgery
and to introduce
so I will
the case.
introduce the patient's information.
Okay, no problem. Thank you.
It's a 45
hello,
years
everyone.
female, and her
Welcome to Dr. Hu Hailong's
OR.
hematuria
we are
was noted
on
7
live
days ago.
surgery.
And
Her past history is so I will introduce the patient's information. Years ago. It's the main 45 years female is only the hematuria. And the content is before the surgery, hematuria was noted 7 days ago, and her ECG is normal, and the chest X-ray only have the age 15 years ago. Cardiopulmonary the main symptom of her is urine hematuria, only have three before the surgery, and the urinary nuclear matrix protein is positive. The ECG is normal. So let's go through her only have the age-related cardiopulmonary changes. And there is a very obvious only have broad-based soft tissue, and the urinary nuclear matrix protein is positive from the right. Let's go through her posterior wall. MRI. Let's switch the camera to Dr. Hu. And there is a very obvious broad-based soft tissue that was noted protruding into the bladder lumen from the right posterior wall. So let's switch the camera to Dr. Hu.
The bladder, no tumor in the other wall.
And I will begin.
I see
this is a young woman and have the tumor in the
far away.
In the right wall
I
of the bladder, and I have
maximized
the bladder, no tumor in the other wall. This is near
I see
near
the orifice of the right
bladder neck.
Very far away.
I will nearly centimeter
margin.
To the bladder, to the tumor, and nearest
I want to
bladder neck tail, and margin. I will nearly 1 centimeter to the bladder.
After Dr. Hu have checked the urinary orifice, and Dr. Hu will electrocoagulation the vessel which supply the tumor, use the laser.
Yes.
After Dr. Hu have checked the urinary orifice, and Dr. Hu will electrocoagulation the vessel which supply the tumor, use the laser.
Yeah, perhaps this is the superior reason. Any question?
Yeah. Actually, the tumor, the mass is actually larger than the MRA.
Yeah.
Yeah, what we see.
By the margin.
Yeah.
Any question?
So I will.
Actually, the tumor, the mass is actually larger than the MRA.
Okay.
Yeah. Also, Dr. Hu is drawing a circle around the tumor. Yeah. The area he can mark and to where he will do the resection.
Margin and okay.
Yeah, also Dr. Hu is drawing a circle around our urologic center, the area you can mark, and to proceed more than 3,000 TURBT per year, and also around 300 radical cystectomy per year. And so also in our urologic center, actually we will proceed more than 3,000 TURBT per year, and also around 300 radical cystectomy per year. And we also ran a lot of clinical trial to treat the UC.
Yeah. Now I will start from the respiration and very near to the bladder neck. I will find the space. Oh, here. 能量大一点，是吧？ Oh, okay, here.
So for now the laser is
是吧？
Dr. Hu using the laser with the OT warp.
Okay. Yeah. Red wall.
So for now the laser is
see the opportunity.
Dr. Hu using the laser with the OT warp.
Yeah. Oh. Red wall. So we don't see the opportunity reflect. Yeah.
这个不好，这个再给我来个连续播的那种，就是20变成20，完了不是连续播，就是那叫什么 off， 就是那个，对，我感觉这个是以气化为主，这个不好，这个再给我来个连续播的那种。就是20变成20，完了不是连续播，就是那叫什么 off， 就是那个，对。
Yeah, Dr. Hu is proceeding unblock resection.
Yeah. So we now use the.
Yeah, Dr. Hu is proceeding unblock resection.
Yeah. I want to find the muscular profile. Yeah.
Yep.
Yeah. I want to find the muscular find the plane here. Yeah.
Yep.
Yeah.
So according to the MRI, the variance score of this patient is about 3. So we will do the unblock resection of the tumor, and also according to the MRI, the variance score of this patient is about 3. Make sure that we will T stage of this patient resection of the tumor, and also proceed to check for the pathology test to make sure the T stage of this patient. So our team in our division, also in our medical center, we ran a lot of clinical trial. So Dr. Hu is well known to running the 2 series. So our team in our division, some of the medical center, already published a lot of clinical trial. Dr. Hu is well known to oncology. Also the CCR series, the clinical trial, the journal. Also some of the studies already published in European seeking the bladder preservation oncology study. Also the CCR, some clinical immunotherapy, the journal was proceeded into the our NMIP patients and MMI patients have a very good bladder preservation study. According to our chemical immunotherapy, the CHOOSE-1 series, we can find that the bladder preservation and MMI patients 4 years have a very good bladder preservation rate, and reached according to our published data, the CHOOSE-1 series, we can find that the bladder preservation of the 4 years,
we're delighted to welcome Professor Wu Zhengjie to join us in this session.
75%.
Professor Wu, can you hear my voice?
Yeah, we can use the C. Hi.
And we're delighted to welcome Professor Wu to join us. Could you please turn on your camera? Can you hear my voice? And the co-chairs, the co-moderates can see you in face-to-face. And Professor Wu, could you please turn on your camera? Then we can, the co-chairs. Today we have two moderators from Africa. The first one is Mobile Companga, and then the second one is Ono JG, Professor. And today we have two moderators from Africa. The first one is Mobile Companga, unmute yourself. And the second one is you can unmute yourself.
So my name is Honore Bette.
Professor Bette, right? Yeah, Professor Bette, okay, you can unmute yourself. You can unmute yourself.
So my name is Honore Bette. Yeah.
Okay, sir. So we can find that the serum laser can have the very good bleeding control than the traditional TURBT resection.
This is the inner.
So we can find that the serum laser can have the very good Dr. Wu is proceeding bleeding control than the traditional TURBT of the bladder cancer.
This is the inner muscle, muscle layer.
Dr. Wu is proceeding the unblock resection of the bladder cancer.
Professor Wu, you can unmute yourself. Right now,
welcome,
you
welcome,
are
Professor Wu.
Welcome.
Professor Wu, you can unmute yourself.
Professor Wu is
right now you are
welcome,
in
Professor Wu.
trial.
吴教授，您的麦静音了。
Professor Wu is our tutor in clinical trial.
你能听到我说话吗
？OK。
吴教授，您
我能听到了。
的麦静音了。
吴教授，我能听到。哎。
现在需要我这个，我不知道前面因为我刚刚手术下来，现在是他手术已经在进行了，我不知道。你能听到我说话吗？那个现在是需要我做什么？那个前面
我能听到了。吴
老
师，哎，吴教授，我能听到。哎。
现在需要我。
吴教授，我们这个环节是胡海龙主任，然后这个做了一个这个激光的膀胱肿瘤的一个整块斑除术，现在也是刚开始，也就刚开始1/3。然后我刚才已经简单介绍了这个病人的一个基本情况。吴教授，我们这个环节是胡海龙主任，然后这个做的一个，然后呢，他的这个肿瘤呢，大概膀胱肿瘤的一个，他的肿瘤我们做了膀胱镜检，现在也是刚开始，也就刚开始的位置呢，在他的右侧。刚才已经简单介绍了这个病人的一个基本情况，是75岁的女性，主要的症状就是血尿，没有您是这个环节。然后呢，它的这个您是这个环节的主持，然后我们就配合做了膀胱镜检，然后这个肿瘤的位置呢在它的右侧壁，现在主任在做这个整块切除。
我们知道。
对，您是线上应该能有几百人的那个非洲的这个，然后我们就配合您看直播。
我主要是这个主持以外，
可以跟他们对话，可以跟线上的嘉宾对话、提问、交流。包括这个没错，线上应该能有几百人的那个非洲的这个同行在看直播。
我们胡主任那需要跟他们对话吗？我是不是？
可以跟他们对话，可以跟线上的嘉宾对话、提问、交流，包括这个点评手术。对话过了也手术刚刚开始。
提问交流可能就是需要我们胡主任来跟他们互动了。我是不是要就是你们现在跟这3位外宾对话过了吧？
对话过了，也手术刚刚开始。
哪些国家的？就是他们2位主持人是什么国家？
喀麦隆。
具体的我们还不是，应该是
他们知道。
问一下这个大会的主持，对。
这没关系，就是他们2位主持人是什么国家？
喀麦隆。
具体的我们还不是，应该是
他们知道。对。
问一下这个大会的人在线上吗？主持人可以介绍一下吴教授的情况。吴教授的简介给非洲的同事同行介绍一下，哎。
好的，那个之前吴教授的情况，那个贝塞老师已经介绍过了。
主持人在线上吗？主持人可以介绍一下吴教授的情况。
非洲马里。
吴教授的简介给非洲的同事同行介绍一下，哎。
卡麦隆。然后这2位主持，那个之前吴教授的情况，那个另外刚刚还有一位上线的专家是然后目前的话呢，就是贝塞老师是来自非洲马里这个刚果金，然后C位老师呢是来自非洲的卡麦隆。然后这2位主持，然后是所以主要还是，然后另外刚刚还有一位上线的专家是抗潘法，您可以跟他们呢互动交流看看，在这个然后他是同样类型的手术里面，他们那边会遇到一些什么样的，但是他那边信号不是那么好，所以主要还是 Siri 和那个 Becker 老师他们俩信号好一点。您可以跟他们2个互动交流看看，在这个同样类型的手术里面，他们那边会遇到一些什么样的情况。
Please, I have one question to Professor Yu.
So, professors, please feel free to ask any question about
how deep can you
the surgery to Dr. Wu or Dr. Hu.
If you found please, I have one question to Professor Yu. Invasive, tumor. How deep can you how deep can you manipulation? If you found. You have a suspicion of
他问您就是说看不见这个肿瘤的时候，你怎么能判断这个它多深
？Tumor. Visual invasive tumor. Okay. How deep can you go?
I think firstly experience. 说他问您就是说看不见这个肿瘤的时候，您怎么能判断这个它多深
I will use the MRI before the operation.
I think firstly experience.
I just know. The tumor, if the tumor is muscle invasive or non-muscle, I will use the MRI before the operation. So
So we don't have any surprise during the operation time,
if the tumor
during the
is
procedure.
muscle invasive or
during the procedure. Okay, you ask during the procedure, not before the surgery. Is that right?
Yeah.
Yes, we don't have any surprise during the operation time.
So Professor Honore,
during the procedure.
your question is if you find
you ask during the procedure, not before the surgery. Is that right?
of the tumor intraoperatively. So what is the next step for the surgeon? So Professor Honore, your question is if you find the invasiveness of the tumor intraoperatively. So what is the next step for the surgeon? That is the question, right? 就是他说你术中发现肿瘤有浸润，那你这个你还能做剜除吗？
那不行，太大，俺都了。
就是他说你术中发现肿瘤有浸润，那你这个你还能做剜除吗？
Doctor Hu said if the situation as Professor mentioned, we can only do the biopsy for the tumor.
Just biopsy, yeah.
Okay, thank you.
And before that, we can evaluate the situation as according to the MRI test, and we can only do the biopsy to evaluate how deep the tumor invasive the bladder wall. And before that, we can evaluate the situation according to the MRI test and the various score to evaluate how deep the tumor invasive the bladder wall.
Less than CRBT or more? What is the risk of bladder perforation?
The risk. The comparison between the laser and the traditional TURBT is your question?
Yes.
Yes. 主任，他问您就是激光手术还有这个 risk 手术这个 the comparison between the laser and the traditional TURBT is your question?
I think all the two surgery
他问您就是这个激光手术还有这个电切手术这个对这个出血啊、穿孔的风险，这个您怎么评估或者怎么判断？
TURBT, I think all the two surgery same in all the laser surgery, and I think a little difficult to is normal, is very normal surgery. So what do you know the laser surgery? I think the laser performance a little difficult, so we will regulate and what do you know the laser performance the surgery, so we will little slow and
Dr. Hu mentioned that the laser operation may be processed a little bit slower than the traditional TURBT, and the laser operation maybe make patients. Dr. Hu mentioned that the laser operation may be processed a little bit slower than the traditional TURBT, and the laser operation maybe make patients have the benefits.
So what is your
benefits from the
do you have any
risk?
suggestion for the indication for late enucleation of bladder tumor?
Here is
So Professor Bessie, so what is your experience? Do you have any suggestion for the indication for late enucleation of bladder tumor?
Very advanced bladder cancer, and Dr. Cyril also we have many cases of squamous cell carcinoma. We mostly know squamous cell carcinoma. Most of them they are very muscle invasive, advanced bladder cancer, and very also we have many cases of squamous cell cancer mostly time. You know, squamous cell carcinoma. Most of them they are early detection of bladder cancer. Here now we found very sub-Saharan Africa, T3 or T4 cancer mostly. I don't have any. We don't have early detection of bladder cancer. Bladder cancer. Here now mostly do sub-Saharan Africa traditional one.
Okay, I see.
I don't have any
neither me.
Enucleation of bladder cancer. I just mostly do GRBT traditional one.
Okay, I see. Neither me. Yeah. So Professor Hu, and what is your maximum limit of blood tumor for enucleation? I mean the tumor size. So Professor Hu,
就是您做这个电群手术最大的极限是多大的肿瘤？
I don't know about
maximum limit of blood tumor for enucleation.
4 meter.
I mean the tumor size.
So
we don't have the
就是您做这个电群手术最大的极限是多大的肿瘤？
I don't know about section. So we 4 meter retrieve the tumor from disease. We don't have the bag for the transurethral section. So
Dr. Wu also mentioned that it depends on the single one or the large area of the mucosa. So maybe 4 to 7 centimeter. Dr. Wu also mentioned that it depends on the single one or the large area of the mucosa. So maybe 4 to 7 centimeter.
4 centimeter. 4 to 7. Okay. So I mean it's just for the if the patients have a multiple tumor of bladder, so less than 4 centimeters. So if the patients have 4. So I mean it's just for the single tumor. If the patients have a multiple tumor of the bladder, so do you have any you can also do the so if the patients have 4 tumor or have you just use the enucleation technique for I mean the single tumor both less than I think 4 centimeter. You can also do the enucleation of the blood tumor, or you just use the enucleation technique for I mean the single tumor.
Don't know how large of the tumor before the surgery. No more than
yes, I see. So my question is if you can still do enucleation for patients with more than 1 tumor.
We really don't know how large of the tumor before the surgery.
主任他问您就是如果
yes, I see.
比如说这病人是多发的，
question is
然后超过4厘米的肿
you
瘤，
can still do
您会怎么选择？
for patients with more than 1 tumor.
是吧，吴老师？
对。
就是主任他问您就是如果要是比如说这病人是多发的，然后超过4厘米的肿瘤，您会怎么选择？
I think once one tumor more than 4 centimeter is very difficult to do this surgery. So I think once one tumor more than 4 centimeter is very difficult to such medical do this surgery. So I don't expect I like to expect the RPT conventional.
Okay, thank you.
Such medical
could you please explain to the audience what is the advantage of the enucleation of blood tumor compared to QRPT?
Equipment.
Okay, thank you. Could you please explain to the audience what is the advantage of the enucleation of blood tumor compared to QRPT?
I think the most important thing of this equipment is don't have operators reflection. I think this it's very safe. The most important thing of this equipment is don't have operators reflection. So I think this is it's very safe to the of the patient surgery the tumor in the F4. The other is no bleed, so I think you can see no bleed very safe. Important of the, but I think this is a little longer. And the other is no bleed. Yeah, you can see no bleed and very safe. But I think a little longer. Then we should find the right plane. Yeah. If we lose the plane, it's very dangerous. So we should find the right plane. Yeah. If we lose the plane, it's very dangerous. So
since I don't have much experience in enucleation of blood tumor, so could you please explain to us what is the best surgical plan for you? Since I don't have so much experience it's all the specimen contain muscle tissue, which could you please explain to us what is the best surgical plan for you to do the enucleation? Is the surgical plan you are doing now? So it's all the specimen contain muscle tissue, or could you show us now what is the surgical plan you are doing now?
You can see this is so it's enough for the this is muscle of bladder tumor. So we can see surgery this is the red not deeper than the RBP, and it's enough for the inner muscular bladder. So we can see if we see in the because we can't. And we can see this is the inner muscular outer of the bladder muscle of the bladder. If we have some little fat, and we can see this is the outer muscle of the bladder. Have some little fat. Not the plan. No, just I want to see the MRI, the MRI scan, and I see I want to see the just I want to see the MRI, the tumor, the MRI scan, and I see I want to see the do surgery, the tumor surgery size in the single tumor case. If the tumor is not in the dome of the bladder, do surgery, do such surgery in the single tumor case, in the position of the tumor not in the dome of the bladder. But we can do it. Very difficult to do. So the dome of the bladder very large. The position of the tumor. And we can do it, but it's very difficult, a little large. So, and I don't do very large.
So to answer Dr. Wu's question, as Dr. Wu mentioned before the surgery, Dr. Wu will read the MRI very carefully and to evaluate the tumor size and where the tumor location. And as Dr. Hu mentioned, before the surgery, the risk of bleeding, read the MRI very carefully and to evaluate the tumor size and to where the tumor located, and also during the surgery we will check the risk of bleeding and to choose RFS first, and we do the section and then choose laser. And
yes,
and
exactly. We need to confirm all the
also during the surgery we will check
Denmark. So I'm interested in
RFS first,
the correct plan you are
do
doing
the section
to follow your enucleation. Yes, exactly. We need to just as you said. I guess you do the enucleation. So I'm interested in superficial the correct plan you are doing to follow muscle of the bladder to follow your enucleation. Just as you said, I guess you is that correct? Do the enucleation, or you do the enucleation layer at the plane of muscle of the bladder, and the deepen explain to us the muscle layer. Is that correct? Or you do the enucleation and at the plane of submucosal layer, or could you please explain to us the surgical plan?
I don't. I just do surgery like this, and the first time I will find the plane. Yeah, just like margin here. I don't. And I just do surgery like this, and then I will. The first time I will find the plane. Yeah, just like margin here. And then find the plane, and then the tumor, and I will use the plane of the muscle and also we can elevate the tumor and fund the plane of the muscle. With count with then I think this is very nice and very near to the plane. And with count we I think this is very nice and the ground plane we will the plane out of the bladder and yeah it's very dangerous. If we have the inner of the plane on the ground plane, we will have the outer of the bladder. Yeah, it's very dangerous. If we have the inner of the plane.
Okay, thank you. Today I heard we have more than 80 colleagues online from Africa. So any questions from the audience? Okay, thank you. Today I heard we have more than 80 colleagues online from Africa. So any questions from the audience? So our president, companion. So our president, companion.
Thank you.
You are muted. You are muted.
Yeah.
Yeah. Sorry.
Yeah,
I was saying
impressed with the technique.
Yeah, it's very nice with precision.
You are muted.
It's bloodless and
Yeah.
Sorry. I was saying clearly, but it's very nice. A lot of time, precision. It's bloodless. What do you think about? We can see every compared to structure clearly, but it takes a lot of time.
Thank you.
What do you think about it?
Your question is for Professor Hu, right?
Yeah.
主任，那个非洲的同事说这个手术非常漂亮，然后解剖层次非常清楚，然后问问您对于这个手术用激光。
Your question is for Professor Hu, right?
Yeah. That's a little like
那个非洲的同事说这个手术非常漂亮，然后解剖层次非常清楚，然后问问您对于这个手术用激光和传统的 TURBT 比，你觉得
we can just find the pain. That's a little like very nobly, very easily. Just little yeah. And we can. But I found it's very important for the pathology and pathologists and very do it very easily. Do it just little. With your time, and they can. But I found it's very important for the pathology, have the muscle pathologists, and we can. So I think do it with some time, do it and better for patients. I think it's if the tumor have the muscle invasive. And
Dr. Hu has said it's very the laser surgery. And patients can benefit from the bleeding control. Also, the unblock section can make patients benefit from the pathology. Who has said it's very the laser tumor surgery. Patients can benefit from the bleeding control. Also, the unblock section can make patients benefit from the pathology test. Because it's the tumor didn't resect it in small pieces.
Nucleation of the tumor and compared to the TURBT, we do have an RCT study from Hong Kong with a level, I think with high level clinical evidence. With nucleation of the tumor and compared to the TURBT, we do have an RCT study from Hong Kong. My question is with a level, I think with high level evidence, where we can have this kind of oncological advantage. Oncological advantage with the enucleation technique. So my question is, what is your understanding of where we can have this kind of oncological advantage?
Tumors see the article and I think because we block is very small good for the tumor. They should do the diagnosis sooner to the medical center clinical trial. So because we find the recurrent patient do the surgery and the real recurrence, they should do the we should do sooner to the in different country clinical trial. So we will find the real recurrence rate and I think the real recurrence rate more and more surgery will select the block the in different countries. I think find the real date good, more and more surgery will select the block and cost a little less time. So I think it has a little bit time and have the best diagnosis and date and good OS rate and so that's a little bit time and good selection have the best diagnosis of the pathologist or the surgeon. So I think all of us will we can for the patient. We can all we will do the two types of the surgery. Yeah, and select we can select the patient. We can and all we will do the two types of the surgery. Yeah, and select just select the patient, the outer and we will training. Yeah, training the implant and block.
Another question to Professor Yu. How long
有个什么样的病人更适合做这个激光剜除？
And I think single
another question to
single
Professor
tumor
Yu.
and
那么您觉得什么样的病人更适合做这个激光剜除
？3 or 4 centimeter single position single tumor and yeah, the most important 3 or 4 yeah, not muscle invasive.
No muscle invasive.
Yeah, is not in the all of the patient can yeah, the most important is non-muscle invasive, not muscle invasive.
No muscle invasive.
So, yeah, if you yeah, of course, if we have some patient can select clinical trial. Select of the MIBC block, I like to choose the block. If you, yeah, of course, if we have some clinical trial specimen of the MIBC, so I like to choose the block because we will do the surgery with the block use the research method. Is better RBT than the use the RBT. So is we will do the surgery, the research use the research method.
Okay, I will do a take-home message for Dr. Hu, what he had mentioned to answer Dr. Wu's question. That what kind of patients can fit the unblock laser operation for Dr. Hu, he had mentioned single tumor less than 4 centimeter. What kind of patients can fit we think we suspect it's the non-muscle invasive laser operation. So that patients maybe have more opportunity single to tumor less than 4 centimeter unblock surgery. We think we suspect it's non-muscle invasive. So that patients may maybe have more opportunity to do the laser.
So I have one question.
Laser unblock surgery. I hope we answer Dr. Wu's question. Is that right?
Yes. So I have one question.
I hope we answer Dr. Wu's question. Is that right?
Yes.
Yes, I asked this question before. So I'm also interested that What is the percentage of re-TURBT following en bloc enucleation compared to asked this question before. I mean, can it also use the re-TURBT? What is the percentage of re-TURBT following en bloc enucleation compared to TURBT? I mean, can it reduce re-TURBT rate?
So we will select your.
You mentioned re-TURBT.
Yeah, use our UTBA to reduce the rate because the biomarker and most re-TURBT is negative. So we will select the research about it. Use the UTBA to reduce the biomarker and so now we will have the research about it and use the UTBA to reduce. Especially in China, it's very TRBT. So we will things now do it. It's just a little center in China, especially in China, it's very bad way. It's very difficult things, and it's just a little center to do it. So little pace, bad way. RBP 卡。Little pace. 哦，对 ，Yeah。RBP 卡。哦，对 ，Yeah， 习惯了。I think it's very difficult to this small mucosal. Yeah. Because we can elevate and we can find we can create. I think it's very difficult to this small mucosal. Is very important. Because we can elevate. And we can find we can create the tension.
Tension.
Yeah, the tension is very important. 是 tension 吧 ？OK， 我说是。哇，这个对，张力。哇
tension.
Yeah, I think
it's a big area.
Yeah, orifice. Oh, yeah. Wow, very difficult. Wow.
Oh, it's
I think
a big area.
This is a young man, so she has a very thin muscle level. This is a young man, so where she has a very she has a very thin muscle level. 它这个止血的效，哎呀，都止血是用哪个模式 ？See where have the bleed? Yeah. 哎，它这个止血的效，哎呀。
So we can see the tumor is en bloc resection and already removed from the bladder wall.
Yeah. Yeah, we can use.
We can see the tumor is en bloc resection and already removed from the bladder wall.
Coagulation effect. Yes. Yeah, we can use the convenience method and have coagulation effect integrator, so we can find the bleeding site. We should reduce the integrator, so we can find the bleeding site. 我说的不对了，你纠正纠正啊！
没事，我是帮着补充一下。
有时候说不明白。对 ，Yeah, basket.
Okay. So after the en bloc resection, Dr. Hu will use the basket, which always used in the RIRS surgery and to take the tumor out. So after the unblock resection, Dr. Hu will use the basket.
Please, a question to Professor Hu.
RIRS surgery and to
Professor Hu.
take the tumor out.
Did you do also during the please a question to Professor Hu? Professor Hu.
I'm sorry, sir, we lost you.
Did you do also during the same procedure?
就是变血管吧，然后咱们把这个创元凝
Sorry.
I'm sorry, sir, we lost you.
哎，那个还给我再来一个变血管吧，然后咱们把这个创元凝
during the same procedure. Did you do also blood mucosa biopsy? That's the first question. I was saying during the same procedure. Did you do also blood catheterization, Foley catheter, blood mucosa biopsy? Did you put the Foley catheter and for how long? The second question, how long you keep?
Okay, good question, sir. 第一个问题就是您就是对还做其他活检，做点活检吗？第二问题是尿管保持有多长时间
？For how long? How much days?
I will
Okay, good question, sir. 问您第一个问题就是您就是对还做其他活检，做点活检吗？第一个问题。第二问题是尿管保持有多长时间
？I will size of the tumor is very large, but is initial tumor size and coagulation and I will size of the I have the impression of the bladder and no tumor, but this size and have the coagulation along the guideline I will biopsy. I have the very impression of the bladder and no this is a woman, but this is very large. We allow the guideline we should calculate biopsy time about 1 week. Biopsy is very important, and I think this is very safe. And if we for the young, we will have a long calculator time about 1 week and very different. I think this is very safe for her, for the young woman.
Okay. Thank you for your question, Professor. Actually, in our center, most of the time we will do the biopsy even for the place not belong to the tumor, and also we will do the biopsy, Professor. Actually, in our the area which most of the time we will do the biopsy. It has even for the so we will always not belong to the tumor, and also for the we will do the biopsy how long we keep to the patient to the area which with the area of the resection. It has some the resection area is big, so we will always do the we will keep the culture for and also for the most of how long we keep that. The normal patient always 2 or 3 days. The area of the resection, if the resection area is big, maybe we will keep the culture for more than 1 week.
I have also
most of the normal patient always 2 or 3 days.
From Professor Mobile. So do you need irrigation after this surgery? Even I can see that there is also one you need irrigation after the additional irrigation from
the irrigation always produced after the TURBT immediately for all the patients.
Even I can see that there is no
except the patients have a very big resection area. The irrigation always produced after the immediately in 24 hours. TURBT immediately for all the patients. Except the patients have a very big and for the irrigation, we always choose most of patients have the chemo irrigation immediately in 24 hours. Within 24 hours, do the irrigation for the immediate one.
Thank you.
Yep. And for the irrigation medicine, we always choose just the chemo drug to do the irrigation for the immediate one. So Doctor Who will use 完事了哈，没有了。哦。Doctor Who is using the stone basket to take the tumor out. Will use 完事了哈。In the hill one, in the whole one. 哦。Doctor Who is using the stone basket to take the tumor out. In the hill one, in the whole one.
哎呀，怎么弄呢？
哎，结束了是不？
结束了。哎，主任，你那什么吧，总结吧。对，来，有点切哈，来。
哎呀，怎么弄呢？
哎，结束了是不？
结束了。哎，主任，你那什么吧，总结吧。
不是我就在这儿吗？
有点切哈，来。
要不在外头在这儿行，还是在外头行是吧？我得对上头啊！哎，
等会儿，
不是我就在这儿，我看手机不让我看见了吗？要不在外头在这儿行，还是在外头行是吧？我得对上头啊！我从这儿接看不了是吧？
应该没事吧？
那我看手机不让我看见了吗？
行。Yeah, I'm here.
And very nice live surgery.
我从这儿接看不了是吧？
Do you have any concluding remarks of the procedure, Professor Wu?
Yeah, I'm here.
Very nice live surgery.
Especially these are.
Do you have any concluding remarks of the procedure?
Good for the patient, for the surgery, lot of the pathology, and these are especially the recurrent. These are do the surgery and we often very good for the patient for the surgery, normal for the pathology. So I think we will do the surgery. We often we will show more of the surgery, have the surgery with the normal surgery fathers. So I think we I think. Surgery we will do some more than of the we can do some clinical trial in this method and found the the surgery we will do some we can do some clinical trial. So thank you very much in this method and
thank you, Professor Wu. Congratulations.
Long-term days of the surgery. So thank you very much.
Thank you, Professor Wu. Congratulations.
别照着我手机吧，上来一点点。
Okay, welcome. Welcome. Dr. Liu Chunyu to have some conclusion about the surgery. Surgery. So, okay. Welcome. Welcome. China. Dr. Liu Chunyu to have some conclusion about the surgery. Surgery. So,
dear Professor Zhang Xu, Professor Nguyen Jue, Dr. Mobile Pampanga, Dr.
So, welcome.
Dear colleagues and friends, hello everyone. Okay. The third CAUA surgery Professor Nguyen on air. Dr. Mobile Pampanga, successful Dr. Today, we observed the outstanding surgical investigations. The third CAUA surgery is highlighted on air. Is precision into a successful close. Today, we observed the outstanding surgical investigations. The robotic procedure highlighted minimally invasive surgery. Precision in complex technology offers the precise the three thulium laser procedures. Fabrication the excellent cutting edge and minimal superfine minimally invasive surgery. It has proven technology available, offers the precise cutting, enucleation, efficient tumor resection, fabrication, and stone management, excellent hemostasis. It also offers practical solution. It has proven resources limited in prostate enucleation, the past year, tumor resection, China, Africa, urological cooperation. It also offers through the practical solution platform for resources limited regions exchanges over the past year, China and the clinical urological cooperation has deepened through the CAUA platform. Improved urological care exchanges on both sides. Professional, modern technology, and clinical sharing have strengthened our goal connection. Better patient care and advanced urological care. This platform strengthens modern technology. It brings us closer. We share one goal. It promotes patient care and more efficient and more precise treatment. This platform strengthens communication. We will expanding collaboration across Africa. Exchange. Together, we will advance innovation, more efficient, strengthen more precise and treatment, improve healthcare. Looking ahead, we will expanding collaboration across smart urology across China and we will advance innovation through closer cooperation and we will bring better care to our patients. Our theme remains us finally. One heart, I think all experts, smart urology, excellent China and Africa. Through closer cooperation for their hard work, we will bring better care, especially recon laser. Finally, not only provide all excellent laser, but they also excellent very good surgeries. I thank China Africa partnership for their hard work. Flourish. Especially urological cooperation, which new not only provide excellent laser, but also offer very good service. Thank you. May China Africa partnership flourish. May our urological cooperation reach new heights. Let's look forward to the next live survey show. Thank you.
Thank you. Thank you.
完成任务了吧？
好，谢谢主任。哎呀，我们选